Welcome to Assembly Health and Human Services. Thank you all for being here. Would the secretary please call the roll?
Assemblywoman Gonzalez. Here. Assemblywoman Garlow. Here. Assemblyman Gray. Here. Assemblyman Hafen. Here. Assemblyman Hibbets. Assemblyman Koenig. Here. Assemblywoman Newby. Here. Assemblyman Nguyen. Here. Assemblyman Orentlicher. Here. Assemblywoman Taylor. Assemblywoman Thomas. Here. Chair Peters.
And I am here. Thank you so much for all being here on our delayed schedule. I want to just extend a thank you for those who have patiently been waiting today. As you know, sometimes the process in this building gets slowed up because we're having to do a lot in a short amount of time. So we appreciate your patience today. We're going to work to get to the bill as soon as possible. Just a few housekeeping items we go over regularly to just kind of clean house, make sure everything is on the table. Before we get started, please mute your electronic devices so that we're not interrupting folks as they're speaking. Members of the public may testify in a variety of ways, all of which are listed on the agenda. You may also submit public comment in writing either in addition to testifying or in lieu thereof. Written public comment may be submitted before, during, or up to 24 hours after the meeting's adjournment. If you wish to testify in person, please sign in by the door and leave a business card so we have a record of your name. If you do not wish to testify, you may also like to sign in case you are interested in participating in the bill and we'd like to get a hold of you. To ensure an orderly flow of discussion, all comments, questions, and responses must go through me. Also, committee members must be recognized before you can speak. Additionally, I ask our presenters on Zoom video to leave your cameras off and microphones muted until it's your turn to present or if I direct any questions to you. When testifying in person, please turn the microphone on to speak and off to listen so that we keep our minutes clean for the secretaries so we can avoid some reverb as well. We have one bill on the agenda and public comment will follow that. I will go ahead and now open the hearing on Senate Bill 239. This establishes provisions governing the prescribing, dispensing, and administering of medications designed to end the life of a patient. As we get started, I'd like to let the folks who are here to testify know because we have quite a few folks who are interested in testifying on both sides, we will limit testimony periods to initial 20 minutes for each support, opposition, and neutral testimony. And if we have additional time based on those who'd like to participate in either of those, we'll reallocate that equally among those support, opposition, and neutral testimonies. Welcome, Senator Flores. Thank you for being here. Please proceed when you're ready.
Good afternoon, Madam Chair, Vice Chair, and esteemed colleagues of the Assembly Committee. I am Senator Edgar Flores, proudly representing Senate District 2, and I am here to present Senate Bill 239 for context and just as a guide to how the conversation will move today. Joining me, I have Dr. Joy Koch and Sarah Mans. I believe most of you have had an opportunity at some point to interact with Sarah, but maybe not with our doctor. Sarah will walk you not line by line through the bill, but will give you a general overview of what the bill does. And Dr. Koch will give you an opportunity to give you her perspective as a doctor and somebody who is in the medical field. I wanted to first start off by thanking everybody who's reached out to me. I've had folk both on a very passionate front against this bill and a lot of folk in a very passionate front and with a lot of personal stories in support and opposition. And I appreciate that because no one I've spoken to yet has not come to the table engaging in the conversation through the lens of what is best for Nevadans, what is best for humans. And I appreciate that because I think we can start the conversation there. If I could walk you just through my personal journey, if I go back 6 years, I personally probably would not have supported this bill. I wasn't comfortable in the conversation. A lot of what I know and how I interacted with the conversation of death was guided through principles that were instilled in me, either through my church or my parents at a very young age. I had the tremendous privilege of saying that I've interacted a very limited amount of times with death. Life has blessed me in that way, that although it's a reality that all of us here are going to die, we can't avoid that. I personally had a very detached relationship. It wasn't until I personally, as I've grown older, and I think that is a reality of life as you get older, you find yourself surrounded by human beings that you care about and love, that unfortunately their time and their calling comes. I say that because it wasn't until my very intimate relationship and interactions with death that then my perspective started to shift. It was no longer just what I was being taught. It was no longer what I had instilled in me as a child, but it was also now a very personal memory. And without getting into detail, because I'm not very good at it. I've tried before, and then it just turns into an emotional relationship with me, and I don't have the words at times, so I will avoid that. But what I'll do instead is say this. In my own family, when we were talking about end of life, and there was a terminal illness, and there was a prognosis of probably just a few weeks left in life for a family member of mine. One of the questions that we had at night while we weren't in front of this family member was, why are we doing this? Why are we keeping this individual alive, as, whether it's an extra day or a couple extra hours, knowing that this human being is suffering so much? And in that relationship and in that conversation, I felt that it was very personal. And for me, I felt that it was very, and people will disagree with this, but I thought that it was very self-serving. Because it was us desiring to keep somebody here longer for us versus us thinking about their suffering. And that was the first time that I started questioning that. That I said, we forced an individual to endure more pain because that's what we wanted. Never allowing the question of the person who was dying and suffering every second of that moment. That was the first time that I started interacting with this question. And I came with this bill last session because of that personal relationship with that moment. I then realized that it was unfair for a legislator through a single moment to dictate through a bill a law that's going to impact the entire state of Nevada. Because, again, remember, the question that started with me is, I felt that it was a very selfish act to force an individual to suffer more for us to be able to keep him here longer. And then I turn around and then I support a piece of legislation that I am now imposing on the entire state. And if I thought the first part was selfish, I thought the second part was even more. So then what I did during the interim, this past interim, thanks to some amazing folk in this building who are here joining me today, primarily Ricky, I allowed myself to go and learn about palliative care, hospice, end-of-life treatment through conferences, because I wanted to make sure that I wasn't acting selfishly, that I wasn't just simply coming in front of you through an emotional bill, through an emotional situation, without having actual data or having an opportunity to get experts who deal with end-of-life care every single day to give me their perspective. But when I went to these palliative care conferences, and when we learned about hospice, and I talked to the nurses, the doctors, the folk that receive you in the front end, the folk that deliver certain items, I talked to all of them. And in that conference, everything that was said was, we want to give a human who is in end of life control. We don't want them to be in a hospital bed in a room that's cold with human beings that they don't recognize. We don't want your last breath to be a smell of an unfamiliar food with folk that you don't recognize, with walls that are not your own. End-of-life care right now, the entire science, if you go to a single conference, is saying, get out of that hospital room. Go to your bed. Go to your room. Go to your backyard. Sit around your family. Cook with your family, eat and do the things that you're accustomed to. That should be the very last thing you remember. And that was really important to me because I realized the entire science of this conversation is in that direction. Because what this bill is talking about is exactly the same thing. When you are about to die and there is a choice between suffering and not, who should control that? I pose the same question because in that end-of-life symposium and in all this science that we've heard about, there's individuals who will be on their hospital bed and get up and leave and stop taking medication, knowing they're about to die because they're no longer taking that medication, and they will go home and do it in peace. That same exact individual will maybe because they're so ill and can't get up and walk for themselves, may have so much pain medication ingested in them to numb their pain that they will die of the pain medication. My question to you is, what is the difference? A human being leaving their hospital bed knowing they're going to go home and die because they're going to stop taking the medication, a human being that you're going to ingest so much pain medication into that you're going to kill them because of that pain medication. Or what this bill now allows you to do, which other states in this country allow you to do, saying when you are going to die and you have a terminal illness and you have a prognosis of death and you've gone to 2 different doctors saying the same, and you've gone through a mental evaluation, and you have to then go get the prescription yourself, fill it, and you have to self-ingest. What is the difference? We are putting death in control of you. And guess what? By the way, all of us are going to be in our end-of-life bed, and all of us are going to choose. Now, some of us may go in the middle of the night in peace, but all of us are going to choose. Whether you're going to stay in that deathbed or you're going to go home, whether you're going to continue taking medication until you die, or whether you utilize this option. And whether you use this option or not, that is using the option. Because this is only an option. Nothing in this bill requires anybody to do anything. It simply allows you the opportunity to have a choice of your end of life. Before I hand it over, because I do think it's important to go through some of these sections, I want to remind everybody that there is an amendment. And I share that there's an amendment, and if you don't have one, I believe it's uploaded in Alice, and there's copies that are in the front. But the reason I mention this, we've amended the bill on the Senate side numerous times. And we are now coming into the Assembly with yet another amendment. The reason I'm saying that is we share the concern. If anybody is concerned that we may target poor people, I hear that often. It is what the single first question I asked. How do we ensure we don't do that? And you think that we could still possibly have something like that happen? Please tell me, we will amend this bill. If you think that there is a possibility of an individual falsifying documents, if you think there's a possibility of an individual getting a fake mental assessment or not getting the second evaluation, whatever you think, and you want me to create safeguards for that, we will continue to amend this bill to address those concerns because we had them going in. We believe that we've addressed them all now, but we will continue to work with the committee with those concerns. And that, we are with you. Where I cannot argue with you and I cannot change the discourse of what we're doing here is through ideological notions. There are folk who have an ideological disagreement, and I respect that 100%. I respect your faith. I personally have a relationship with death. You have a different one. I respect that. But on the policy side, we can have this conversation, and we can work together on the policy side. I am not here to tell you what you should believe in terms of God. But in this building, we discuss policy, and I am here to discuss that alongside you, and I think that is our duty. If I could invite both Sarah Mans and Dr. Koch to please join me so that they could continue the conversation through their respective expertise, their lens through their expertise, better said. Please.
Welcome.
And I'll hand it over to Ms. Mans first.
Please remember to state your name for the record before you speak so that we can keep track of the minutes. And you may begin when you're ready.
Thank you, Madam Chair. Sarah Mans, Compassionate Choices Action Network. And as the Senator has movingly described, we are here to talk about how the Nevada can implement this policy, and that's what this bill does. And I've spoken with, I think, most of you on the committee. So what I'd like to do is very briefly describe what the bill does and then hand it over to Dr. Joanna Koch, who has experience in providing medical aid in dying, because many of the questions that you all raised with me when I spoke with you individually had to do with what is this actually like? And so what I can tell you is what the bill does, and then she'll be able to tell you more about what the process is. So the End of Life Options Act allows a terminally ill, mentally capable adult with a prognosis of 6 months or less who is suffering from an incurable disease to ask their doctor for a prescription medication that they can voluntarily take when they are ready to peacefully end their life. Now, I'm going to break that down into its pieces. So, what are the eligibility criteria in order for you to begin the process if you're a patient who has a terminal diagnosis? Well, there are three. Terminal diagnosis with a less than 6 months to live projection, and of course, doctors make estimates. They can never tell us exactly. Sometimes those prognoses are very long compared to what actually ends up occurring. Sometimes they're shorter. But 6 months is the requirement to enter hospice care. So terminally ill, less than 6 months to live who has patient has an incurable disease, they need to be mentally capable. What does that mean? We had a lot of discussion in the Senate Health Committee on the subject of what is competent, what is capable, what does that mean? Well, it's really simple. Mental capacity is the ability to make medical decisions for yourself. And one of the protections that's written into this bill that is incredibly important is no one can decide this for you. You have to ask your doctor for it, and then you have to pursue a process that I'm about to describe to you. So you have to have the capacity to consent to medical care. A person has capacity when they understand the information and the consequences of taking medical aid in dying. They are able to assess alternative options, and they can communicate that decision to their healthcare providers. So those are the baselines of what you have to do to start asking your doctor. This is a medical aid in dying is a trusted, time-tested medical practice. It is authorized in 10 states and the District of Columbia. And over the 25 years since Oregon first authorized it, the policy around how to make sure that we can be confident that patients are choosing this for themselves and that doctors are following the rules in order to make sure that they prescribe to people who are able to consent and understand and qualify. That has become more sophisticated. So I'm not going to, this bill has, I think, we have 19, 20 sections. And I'm not going to go through each one of those because I know that you've all had the opportunity to read it. But I will kind of give the high points. So there are two providers involved in this, the attending provider and the consulting provider. So two providers have to agree that this person is qualified, terminally ill, mentally capable, adult over 18, short time. Those providers have to inform the person who asks them about medical aid in dying about the full range of their end-of-life care options. If they ask about it, this is included in that list, but they can't just say yes. They are required by the statute, and that's actually what's in the amendment that we're bringing today. They are required to make sure that the patient is aware of all of the alternatives. That's part of what they have to do to be protected by the statute. No physician, no APRN, no one has to provide. They don't have to participate in this. If you as a pharmacist believe that this is a wrong thing to do and you can't do it, you do not have to fill that prescription. That's an important protection because people do have, as the Senator referred to, concerns. and don't want to participate. And so, of course, we want to make sure that those people are protected in their expression. The patient can withdraw their request for medication. They don't have to take it, and they can always change their mind. The patient has to be able to self-administer, so that means they're going to ingest the medication themselves. No one can give it to them, and no one can, the doctor isn't administering it, the patient is administering it. That's important because it's our door into one of the questions about this policy that the senator referred to, which is whose decision is this? Who is the person who is choosing when it's time? Well, that's always going to be the patient with this. So that's an important protection. They have to self-ingest. They have to make this decision for themselves, so that we know that they're the ones. A lot of questions come up around how is this documented? And I'm going to just be very brief because I know we're going to have questions about that from the committee. Life insurance payments will not be denied. This doesn't impact estate at all, because the death certificate lists the underlying terminal illness. And the doctor can talk more about that. And let's see. The mechanics include, and this is important, 2 separate verbal requests, 15-day waiting period between them. In that time, the patient also needs to make a written request, and this bill provides for a form in which that has to be done so that it's easier for the doctor to be absolutely certain that they have complied, so that they're getting the liability protections from this bill, which is important for doctors. There are documentation, medical record requirements in here, and they have to make those records available to the State Department of Health. The unused medication, this is a question that came up in the Senate, interestingly, is disposed of according to state and federal law. Let me mention about that nationally, about 93% of patients who pursue a medical aid in dying prescription are in hospice and palliative care. Most of them are looking for this because their hope or their plan is to pass away peacefully at home in the event that their disease progresses in a way that makes it intolerable to them. That means that their house is full of medications, because if you have been with anyone in home hospice, you're aware that there's a lot that they bring over to you, and then they say, give this to the patient, and that whole thing. So these medications will be, in the event that they are not taken by the patient, will be disposed of along with all of the other pharmacopoeia that is in the home with home hospice. And what I want to close on is, this is an incredibly popular policy, and I'm not sure that matters, because you're not here to necessarily validate the public, but I do think you should know that when we explain this to people in the language I have just used with you, a remarkably high percentage of them say, yes, I would want that for myself. And yes, I think Nevada should allow me to make that decision if I consult with my family, my spiritual advisors, and my doctor, and that seems like it's what's right for me at the end. So I wanted to share those with you all, because they're pretty remarkable. We don't see a lot of policies where rural counties and Clark County approve at 80%. That's not something we see a whole lot here, and I just wanted to kind of elevate that. And I want to turn it over to Dr. Koch, who has many years of experience in hospice, because she can tell you more about what does it look like when someone chooses this.
Members, thank you for having me, Assembly members. My name is Dr. Johanna Koch, and I am speaking in support of the Medical Aid in Dying bill. I am the medical director of the Summit View Hospice in Reno, and 2 years ago, I had a patient with advanced cancer that was no longer responding to treatment. The drugs needed to control his pain rendered him so sedated he could not function. His suffering was so great that he told us he just wanted to die. We provided spiritual support, emotional support, psychological support, frequent medical visits, frequent nursing visits, and aggressive palliative care or symptom management. Despite this, he begged us to help him die. While receiving this excellent palliative care, on one cold winter morning, he called the police and he informed them that there was a dead body in his garage. He then went out to his garage alone, spread out a tarp, and laid down on it and shot himself in the head. No one should have to resort to a desperate measure like this when our medical system could have provided them a peaceful alternative. This broke my heart. And no first responder or hospice team member should have to walk into a home and see that in front of them when it could have been avoided. I am a board-certified family, hospice, and palliative care physician. I am and have been a practicing local family doctor for over 35 years. I also have been and am a hospice medical director for 20 years in both the state of Nevada and neighboring California. As a hospice physician, I have cared for over 3,000 patients through my hospices. I have prescribed medical aid in dying for less than 40 patients. In contrast to the story above that is so tragic, my experience with medical aid in dying in California is that it affords the opportunity to have a warm and loving environment with time for sharing and closure and lots of love. One of my patients in California waited for 2 months near the end of his life with cancer while his family worked to come to terms with the reality and the finality that his life was ending. Once they were finally on board, he was able to get his wish. After completing all of the steps required by the law, he obtained his medication. On the day of his death, while I was preparing the medication, he and his family members watched a video compiled by friends and family wishing him bon voyage, reminding him of some of the funny things that had happened in his life, and telling him how much he was loved. The family encircled the bed and reminisced with him, and when he took the first sip of the medication, he stopped for a moment, took a deep breath, laughed, and said, "Oh my God, this stuff tastes like something else." His family also began laughing as he drained the cup and fell asleep. He died peacefully a few hours later, and in my experience, this is actually representative of medical aid in dying deaths. I have heard there are many fears regarding this bill, as were mentioned here. I can only tell you that they have not manifested. There are 67 cumulative years of experience within the participating U.S. states that have never shown any systemic abuse of the system, that have never shown any inappropriate use of the medication. The law is written to prevent those things, and it works. The majority of Nevadans support medical aid in dying. There are many of them in our state today who are wishing for a gentle and peaceful death in their own homes, surrounded by their families, and on their own terms. For your constituents, this legislation must be passed. Thank you.
Thank you. We ready for questions now? All right, we have several. I will start with Assemblywoman Gonzalez.
Thank you so much, Senator Flores, for bringing this bill. First, I just wanted to make a comment about your willingness to hear everyone's concerns. When I was looking for the bill, there were so many different versions of it. I almost had a hard time finding the correct one. So I just want to say thank you, and I think it's critical in the lawmaking process that we do address concerns of our community. I have a few questions, if the chair will allow me. First, I want to know, why is there this narrative that this would be forced upon someone? I feel that I've read the bill, I've heard your hearing, and I don't see anything that would force a person to go through this process. So I'm just curious where that narrative came from and why we're hearing that. Thank you.
My ask is just to remember to say your name for the record before you speak, so we just have clean minutes. Thanks. Please go ahead.
Sarah Mans for the record. Thank you for that question. And the answer is that many people fear that historic abuses in our healthcare system against people of color, against poor people, against people with disabilities, will be recapitulated in this process. And that fear is completely understandable because those abuses have happened. That is real. What we also can be confident about the practice of medical aid in dying, is that it will not be possible under this legislation to force it upon anyone, because a disability is not a terminal condition. You might develop a terminal condition if you have a disability, but those are two completely separate categories. And the anxiety and the fear about that is completely understandable, because we have to be honest about the fact that there have been abuses. But this practice is not vulnerable to abuses of someone who, for example, one of the concerns that I heard someone articulate was, well, what about if someone is going to be coerced into this? Well, the process for this is pretty onerous. It's complicated. It's difficult to go through all these steps, and it also requires the patient to, typically the medication isn't even covered by insurance, so it actually can be very difficult to access, and certainly we have not seen in any other state that this has been kind of forced on anyone. But again, as the senator said, it's important to be respectful of those concerns because they are based in a reality. This policy, as encoded in this legislation, is not vulnerable to that. But it's understandable that someone will be worried. So that's why you'll hear that, I believe.
So much. My next question is a data question, and I was curious, in the last year or maybe 5 years, how many people have used this in those other states?
Thank you.
Will you state your name for the record?
Sarah Mans, for the record. I can't tell you that close of a window. I can tell you over all jurisdictions in the past 20 years, just over 6,000 people have used medical aid in dying. So that's 67 cumulative years. That's not a lot. Less than 1% of the people in each jurisdiction where this is authorized use the law each year.
Thank you so much. And then I was curious, so you touched upon there being concern that this would impact poor people. I was curious if you had data on the socioeconomic backgrounds of those people in those states that have utilized this.
We have limited data, and the reason is that we don't get consistent reporting across all the jurisdictions, obviously. We can tell you the kind of overall demographics, and I'd be happy to do that. Nearly equal use among men and women. The rate at which Asian, Black, Indigenous, Latinx people access and use prescriptions under medical aid in dying laws is consistently lower than the rate at which white people use it. Most of the people who use medical aid in dying have a terminal cancer diagnosis. That is the by far most common diagnosis. And let's see. And then the challenge that we face with giving further demographics among these jurisdictions is not just that they're all different, it's that there's a federal law that restricts the use of funding through any Medicare or Medicaid program for medical aid in dying. And for that reason, individuals who are reliant on Medicaid and Medicare at the end of life often cannot access this, even if they want it.
Thank you so much. I feel like that disproves the point that this would impact low-income people. As I'm reading this, in the safeguards, you have that the patient has to be seen by 2 different doctors. If there is a concern about their their mental state, they're then referred to a mental health physician. To me, that sounds like a lot of copays and maybe even paying out of pocket because your insurance company is not covering this. And so I just wonder where that argument came from, that this would impact low income people, because what it sounds like to me is that you do have to come out of pocket for this, and for many different appointments, including the medication, which I don't know if we discussed the cost of that. Can you maybe also touch about that too, please? Thank you.
Sarah Mance, for the record. Yeah, it's about $700. So that is not insignificant for someone who depends on Medicaid and Medicare coverage. But the point that you raise is actually something I would like to highlight a bit, which is the very fact that this can be expensive and can be a lot of copays means that the argument that this is somehow going to be thrust upon people who are not actively seeking it is a little tough to understand, simply because if it were up to the doctor or the hospice practice or the hospital, they can cover every single possible treatment that a person might pursue, but they can't cover this one. So anything they could do to potentially extend their life, anything they could do that is a treatment that could maybe give them more days and more hours, that's paid for, but this is not. So that is, I think, a fairly significant protection against doctors pushing this or suggesting it to patients.
Thank you. Assemblyman Gray next.
Thank you, Madam Chair. And I'll beg you to bear with me, and the community to bear with me. It's such an important and emotional topic. You know, I will say, just since the beginning of the session, some folks know I've had 3 family members die, and actually all 3 of them probably could have fallen into this class. So I do have some questions. None are meant to be inflammatory. They are truly fact-finding. The first question is, why do we have to codify this? Most doctors and patients have a relationship that when you are actually close to dying, at end of life, they will make you as comfortable as you want to be, meaning if you want to push the meds, have at it. And they understand it. They don't want you, first do no harm. They don't want to see you suffer undue pain, in your final moments. So why must we codify this?
This is Dr. Koch. So the reason we codify this is because what you're talking about is, first of all, illegal. In other words, what you're asking a doctor to do is illegal. You're asking them to give a patient enough medication to kill themselves. And while I understand that there's a nuance there, you can say, here's the bottle of morphine, this is how much you should take, and I'm not going to look if you take more than that. It's so imprecise, and some people do not respond well to that approach. And instead, you end up with complications that end up with hospitalizations and ICU stays and people dying in ways they had no desire to have happen.
Okay. Following him? Thanks. So the bill says, and this is one I have another real problem with, it says that the death certificate must not, must certify that the death is second or is primary due to, whatever the terminal illness was, and must not even mention the suicide. I mean, that is that's a lie that actually could defraud insurance companies that have a suicide clause in it. I mean, like it or not, that clause is in there, and I have a hard time with that. Why can't, if they're going to choose that route, why can't they choose that route and go with ramifications of that route?
Dr. Koch speaking. So I have probably completed somewhere close to 3,000 death certificates. Each time I complete one on a patient, I have to sift through the various possibilities of how to complete it in a way that I think represents their journey toward death the most accurately. For example, if a patient dies of dementia, I put dementia as the primary diagnosis on their death certificate. But it might be more accurate to say that they died of heart and lung and other organ failure as a result of protein-calorie malnutrition, as a result of swallowing difficulties or digestive absorption difficulties that were caused by their dementia. But I think it serves all of us better to put the diagnosis of dementia down for that patient rather than those other extenuating circumstances. Another example of that is a patient who dies of congestive heart failure. Would it be more accurate to say that they drowned in their own fluids as a result of their heart failure? I don't think so. And so a patient who chooses medical aid in dying is not doing so because they want to kill themselves. They aren't suicidal. Suicidal is a legal definition, and these are not people who are suicidal. These are people who have usually fought for every day, week, month of life that they could get. But they have finally realized that they don't have the choice to continue to live. It may be a matter of days or weeks, but they know that their life is coming rapidly to a close. And so, as strange as it sounds, the real reason that they're doing it is not to kill themselves, it's to stop their suffering. So to call that suicide misrepresents it. Yeah.
And Madam Chair, one final question. Okay, so you, to end your suffering, I'm sorry, did you want to say something, ma'am?
Sarah Mans, for the record, you kind of asked a two-parter, and I'd like to answer the second part, which is about the life insurance aspect. Oh, I'm sorry. The life insurance lobby actually raised that same point. And so we did some work in the bill so that they could feel comfortable with it, because their concern was having someone decide to do this. Their concern was, why is there a suicide clause, right? What's the reasoning for it? Well, it's because what they don't want is to have someone decide to end their own life that otherwise would not end, get a policy, and then they have to pay on that policy. Because that'd be fraud, right? Because the person knew information the insurance company did not have, which is that they intended to take their own life. This is different because the person is dying anyway. So the life insurance clause in this bill says that they have to pay because what's happening is the timing of the person's death is changing by a very short margin usually, but not whether the company would have to write a policy. So they reserve the right to not write a policy to someone who is dying, as of course they should be able to, because they should not have to pay if someone is gaming the system in that way. However, this is acceptable to them to pay because what's happening is the person's timing of death is changing, usually by a matter of days or weeks, sometimes as much as months, but it's hard to say.
Okay. And just as a quick follow-on to that one, I didn't expect this, but what about the missed premiums they would have paid? Because that does cause financial harm. Is the bill going to require, if you had 6 months to live and you say at 3 months that, 3 months of premiums are going to be deducted from that? I mean, that's still, and you don't need to answer that. Those are the questions that are coming to mind.
And if you'd like to respond, that's fine, but that's also a question that the insurance industry might be better poised to answer because
Thank
it
you.
affects
What I was
them.
thinking.
Yeah. Did you have one other follow-up
I do.
outside of that one?
Just
Please
this
go ahead.
last one. So you said, Doctor, I forget your last name, Koch. Okay, I'm sorry. To end pain and suffering, I'll be the first here to tell you, I have and had and suffered from PTSD. I'm a 26-year military guy. Pain and suffering is real when it goes to that. The depression is real. The mental competency can be very questionable at times. What about, somebody in that case? Why don't we just put on their death certificate that it was due to depression or PTSD? Because I've yet to see a veteran who's ended their pain and suffering, which is very, very real. I'm here to tell you, very, very real. Why don't we put it, that as the cause of the death instead of suicide?
Dr. Koch speaking. So the difference is that person that you're talking about, they were suffering and they chose suicide to put themselves out of their suffering. But they didn't do that with the support of a medical team that did their best to fix their problem. And the veteran who goes out on their own and kills themselves, or the person with PTSD for some other reason, is not doing so in a protected and safe and nurtured and supported environment where everything that could have been done was done to save their lives and to keep them from suffering.
Appreciate how sensitive this topic is to folks. Assemblyman Gray and I share a lot of feelings around PTSD and the impact that that has on our friends and family. We will move on to our next question from Assemblywoman Taylor, please.
Thank you, Madam Chair. And again, with your indulgence, I have a couple of questions, if you'll allow. So thank you, all of you, for being here, and to our colleague, thank you, Senator, for presenting. A couple of questions. I'm going to ask questions. We've all received many emails on this, I'm sure, sir, and both of you can imagine. So I'm going to ask a couple of questions related to those emails, if possible. My first question would be, some of the emails have centered upon, well, the idea that insurance companies, then let's say if someone has received a terminal diagnosis, and I think that might be part of the difference, as my colleague, Assemblyman Gray, in terms of someone who suffers with depression and PTSD, they haven't received that terminal diagnosis, right? But let's say if they have, whether it's because of that or other reasons, and so some of the questions I've gotten emailed to me and personally is, so then that would encourage insurance companies to say, we're no longer going to pay for your treatment, because you can take this suicide pill, if you will, and then that means you'll die in a couple of days instead of in 5-6 months. Has any consideration, are insurance companies allowed to say, well, you've gotten a terminal diagnosis, so you have to take this pill, or we aren't going to support your treatment going forward? Does that make sense? If you would,
Sarah Mance.
Ms. Mance, thank you.
Sarah Mance, Madam Chair. Yeah, that is actually something I've heard about a lot. And here's the thing. The math doesn't really work, because if you're qualified for this, you're qualified for hospice. Hospice pays for a wide range of treatments, and you can choose in palliative care, which you also will be eligible for here, to continue to fight your illness and treat your illness with everything possible. There really is no opportunity for health plans to save money with this, because the people who are eligible to even request this in the first place are already at the end of all the expensive things that can be done. That health plans, they've already paid for all that. And so they're at the end of those typically. But the math doesn't work, because the hospice coverage will cover, however long. The health plan will, they'll do just as well, giving coverage for treatments beyond the point. I mean, what we see when we ask people, do you want to do everything? Most people say, I want to die peacefully in my own bed at home, not I want to be in a hospital with a machine that goes beep, right? So obviously, 80% of people say they want to be at home. That machine that goes beep in the hospital is extremely expensive, but health plans pay for that. Medicare pays for that. Medicaid covers that, but they don't cover this. And so it's not really an opportunity for them to save money, because they're going to they cover those things, and they're compensated for them. So, and typically people are beyond the point of that.
If I can just, and you've allowed a couple of questions, but a follow-up on this one, Ms. Mans, if you will, then I guess I want to dig in a little bit further from the question standpoint, because the way I've heard it is that, well, insurance companies will say they aren't going to keep paying for that machine that goes beep. For that person who says, I want to fight this till the bitter end because I love life, I don't want to go, right? So, and then the machine that goes beep is very expensive, but an insurance company would say, we aren't going to continue to pay for that because you can take this suicide pill. I mean, that's the nature. Is that more clear now? That's the nature of the questions I'm getting around this.
Sarah Mance, thank you so much for clarifying that so that I can give a more clear answer.
Thank you.
I appreciate it. Yes, insurance companies cannot send people to this remedy. The individual must request it. The health plan cannot change what they cover based on this being available. And in 10 states, starting 25 years ago, I believe that if health plans could have found a way to do that, they would have, because we all know how that is. They're trying to make sure they're controlling costs because our system's very expensive. With respect to that, we have not seen that. And I believe the reason is that by the time the individual has to make the decision that they want this, they have to pursue it through this process. No one can make them do this process, and no one can tell them that they have to. And health plans do sometimes say this treatment is experimental. It does not show 5% improvement in time for 5% of the patients. It doesn't even meet that very low threshold, and therefore we will not cover this treatment. That happens in Nevada today. That happens in every state without regard for medical aid in dying, and that will continue to occur. If this is authorized in Nevada, we will continue to have patients whose insurance plans say this treatment does not pencil out. We don't believe it's likely to lead to more days of life for you, and we are not going to pay for it. And that is part of our system, and it's going to remain true after this.
Thank you. I
Is that a better
appreciate-
answer?
No, I appreciate that. Thank you very much. Some of the emails named a couple of states that are doing it all the time. And so, and you said your research has not found that. So that's just something. No, it's just research is a wonderful thing. So that's something we can certainly find out. I'll go on because I know others have questions as well. Another email that was the question that was sent to me often was these medications, whenever they're being used for those who request them, and I know most of them that request them don't end up using them, but nonetheless that they're there, that they are not approved by the FDA. Doctor, thank you.
This is Dr. Koch. The individual medications that are used in the end-of-life cocktail are each of them approved by the FDA. The combination of them is not approved, but there isn't one single combination. A prescribing physician may choose to prescribe whatever they feel is the best cocktail, if you will, for that patient. There is some work being done to collect data on this subject so that we can learn what works best. But that's as far as it goes. So no, there's no specific FDA approval for the formula because there is not just one formula.
But each individual medication, does it have FDA approval?
Absolutely.
Okay, and then my last question is, just in terms, you spoke about the process because you've been involved in this many years, Doctor. So in the example that you gave, and the gentleman who was there with his family and they watched the video and so on, and then he drank the beverage and then laid back, do they just fall asleep?
So the average person falls asleep within 10 minutes. In fact, I think over 80% are asleep within 10 minutes. And then they never wake up. And that's an absolute. There's never been somebody who woke up from the end-of-life cocktails. The next step of actually dying can take anywhere from minutes to hours additionally, and most deaths occur within 2 hours.
Okay, thank you very much. I appreciate those answers from all of you. Thank you, Chair.
Thank you. And that was Dr. Koch for the record. I'm going to go to Assemblyman Hafen next.
Thank you, Madam Chair. And Senator, it's great to see you on this side of the building, back on the third floor. I wish it wasn't in this hearing, as we've done this a few times now. Today, we're talking about the difference between death with dignity versus murder. We've had conversations about the cost of a beeping machine, which I don't find relevant to this conversation at all. And I've heard some things that are actually upsetting to me. We sit here in this committee, time in and time again, listening to, we have a mental health crisis going on right now in this state. A lot of it is due to the pandemic and the lockdown. And we are trying to address that right now with legislation. The statistics that we're being presented is that 1 in 4 people are going to go through a mental health crisis or mental health issues throughout their lifetime. There's 12 legislators sitting here today. That means 3 of us at some point in our life are going to have some sort of mental health issue, whether it's depression, anxiety, or others. And what we're seeing in other countries and other states that are doing this is they're allowing this for depression. Other states in this country are allowing this for anorexia. And in those other states, we're now seeing a substantial increase in suicides, not assisted suicides, but suicides, some states up to 40%. And Senator, you know how much I respect you. And I know you mentioned there were safeguards, but I'm struggling with these safeguards today to see how we're going to prevent our youth, our citizens that are struggling with mental health from being one of those 40% statistics in the other states. So please help me understand the safeguards that you're putting into place to address those other individuals that are not at the end of life, but are struggling with mental health, and see this as an alternative to an out when they could be getting actual help.
Thank you, Assemblyman. Senator Edgar Flores for the record. Madam Chair, through you to Assemblyman Hafen.
Please feel free to go direct.
Thank you, Madam Chair. So I'll say a couple things. The first thing, and it's incredibly important that we start the conversation, that there must be a terminal illness and a 6-month or less prognosis of life, right? And the reason I'm saying that is mental health is a huge issue. Mental health is something that probably we'll be dealing with every single legislative session for the rest of every individual's life in this body. Because we still don't understand so much of it, and all of us are probably committed to working and improving it. But I'll start off there, because that immediately captures a whole group of folk that simply will not engage in this conversation because there is no terminal illness and the 6-month or less prognosis. Second, this does not apply for anybody under the age of 18. So for our youth, and we know it's a huge issue with our youth, mental health, this won't apply to them at all. And number 3, and equally as important, we got to remember that there has to be from the individual who's been diagnosed, who is suffering, out of their mouth, there has to be a conversation. There has to be 2 different doctors who make the same finding and agree. And there has to be a mental health assessment. There has to be. And then on top of that, you then have to go and fill that prescription. You then have to pick it up and then take the medication. All of that needs to happen. That entire process. And that doesn't happen in a day. I've had conversations with folks saying, look, we've all been in a moment of crisis. And I'm concerned that an individual in a split moment of crisis will make a decision that is dictated by the deep hole they are emotionally in. But this entire process that I just told you about cannot occur in one day. In one day, you're not going to have 2 independent doctors, a psychologist, a prescription, a pickup, and taking it all in. It's going to be in a course of time, and I'm not suggesting that that's months either. But I just want to make it abundantly clear that it's not going to happen in a single moment. And I also want to make it abundantly clear that these psychologists, the 2 doctors, all of them are assessing this, right? There's no reasonable doctor who believes, and Dr. Koch can talk about this, who believes that this should be an option. That if they see that there is a specific scenario happening, the coercion, folk pushing folk into a certain position, whatever that may be, that they themselves are not saying, well, wait a minute, I need to engage in this conversation a little bit deeper. I believe there is coercion. And we're putting all that in this bill because we very specifically know that that could happen. But we just want to remind folk of that. And I also want to make it abundantly clear, and it goes back to the Assemblywoman's question. There's been 67 years of this. 6,300 people in all the states have utilized it. 6,300. If the data and a lot of the myths that are out there were true, it wouldn't be 6,300. It wouldn't be that in just a single state. It would be if the notion that the insurance companies are somehow going to be pushing everybody towards this direction. It'd be in the millions by now. I mean, just think about how many human beings have a terminal illness every single day in our country. So I just think that if all of that were true, the data would be very different.
I'm going to be respectful, Senator, because I do consider you a friend, but you did not answer my question. My question had nothing to do with the assisted suicide, but my concern is that we're in a mental health crisis right now, and the states that are doing this are seeing a substantial increase in unassisted. Don't shake your head no. I'm reading the data right here. I don't appreciate that. I find it very disrespectful. This is a very, very serious conversation that we are having about mental health, and I would like to know what safeguards are being put into place so that our citizens are not looking at this as an out and a justification for unassisted suicide. And I would like to have that question answered.
Sarah Mance for the record. The chart that I'm looking at, which is CDC data for the last, since 1993, which was when the first medical aid in dying law was authorized in the U.S., shows the suicide rate of the 5 states in which it was first authorized. And there does not appear to be any correlation. I'm happy to enter this into the record. There doesn't appear to be any correlation between rising suicide rates, which are a national trend, and they are a tragedy and certainly a problem. But there doesn't appear to be any correlation whatever between states authorizing medical aid in dying and their rising suicide rates.
And Assemblyman and Senator Edgar Flores, for the record, we could also share this specific chart with the entire committee so that you can see specifically what we're referencing. And I'm not sure, Assemblyman, what specific data you were looking at, but we are more than happy to share this specific data point so that you can see our position on that.
I would appreciate that information, and then just so the record's clear, there is no safeguards put into place for the unassisted suicides in this bill.
And thank you for that, Senator Edgar Flores, for the record. And I do apologize. I thought you were referencing specifically this bill, and that's why I went down that talking point. But I agree with you that this bill does not address suicide in general, conversations about suicide or mental health outside of the scope of a human being who has a 6-month or less prognosis, terminal illness. And I do agree with that. But this bill does not address anything outside of that scope.
And Senator, again, I have the utmost respect for you, and so I just hope you understand my concern when we're in the middle of a mental health crisis and what we're doing by normalizing this, and my concerns, and that we need to be doing everything we can to get out of this mental health crisis and then have this conversation. And I genuinely respect you again, but I'm going to have to disagree. And
I appreciate.
Madam Chair, I'll turn that over to you.
I appreciate your comments, and we've spent a lot of this session talking about mental and behavioral health and the deficiencies in the state of Nevada, and I appreciate the point, Senator, that we're really focusing on the bill at hand, which unfortunately does not have the full scope of policy related to public and behavioral health. Neither has most of the bills that we've heard in this committee. So we will go to Assemblyman Nguyen next.
Thank you, Madam Chair. This is a difficult topic, and I know that I've been getting a lot of emails over this, just like all of my colleagues, and so have you, Senator. Assembly District 8 is one of the most diverse assembly districts in Nevada, with at least a couple of dozen languages and background. And Ms. Mann, I believe I covered this with you a little bit when you talked to me in my office. Many of these families are just not aware of options that are available. All these options, all these medical availability out there. And sometimes it could be a language barrier, it could be there's too much information out there, or simply not enough. I just learned recently about palliative care not too long ago, and we did a focus group on that with the Asian community and see where their understanding of that, and hospice care, and some of these immigrant community, and I am an immigrant. I wasn't born here, and I grew up in a bilingual household, and every time there's a life event, whether it's a happy one or a sad one, we struggle with the understanding and the dynamic of the complexity, can't say the word, complexity of the options that are available. I need more caffeine, Chair. And a lot of the opposition that's coming through, I get it. I get the opposition that's coming through is about, mostly all of the emails I've been getting is about losing control and not having choices, that this law is gonna force control out of their hands and not be able to have control, not choices are being taken away. And those are most of the concerns. But going back to the bill, just addressing that part, and I want to make sure folks have the ability to control this narrative in terms of making this as part of their process when they choose their end-of-life option. Section 25 of the bill addressed a requirement for a written form in English. And I'm concerned that that would, again, doing that same thing that I talked about earlier, eliminating a very good segment of our community from being able to utilize this law should it come pass, right? And for folks who have language barrier, sometimes from a literacy piece, they can't even write in English. Having this part just for this one language only could be a disadvantage of implementing this law should it pass. So I'm just trying to speak out for the immigrant community who my district is mostly comprised of, has a lot of challenges in navigating some of the current things already. So in terms of when we make these changes, I would like, Senator Flores or any of the folks here on the dais trying to see how we can work with folks who might be not able to write, not able to read in English, or not be able to verbalize their requests in English, that there is a some sort of process that would allow those families and those patients have the ability to communicate their wishes and have it being done correctly.
And Assemblyman, thank you for that question. Senator Edgar Flores, for the record. I think it's an incredibly important point. I identify with a lot of your story, maybe different backgrounds, but very similar immigrant story. And I appreciate you kind of being so in tune. In fact, I know that you're working on ensuring prescription medication is in different languages, and I appreciate and applaud your work for that. I would like to turn it over to legal. Maybe our legal could provide just some guidance in terms of presently what the requirements are when providing any information, when a physician or a doctor is providing any type of medical care, what the requirements are now to provide that in any other language. If the answer is, in general, there is no real requirement that it be provided in any other language other than English, then absolutely, then what I would do there would be to ensure that we mandate that this be provided in the language preferred by the patient. But I don't know enough about what the standard practice in the medical community now is when providing XYZ, so maybe our legal could jump in on that. I would appreciate their support.
Thank you for the question, and I do want to point out that our own Assemblywoman Torres has been working on cultural competency in the healthcare industry and specifically addressing some of these issues, but I would go to Mr. Robbins, please.
Yes, Eric Robbins, LCB Legal for the record. So basically when someone receives care, they have to provide informed consent to that care. And so that informed consent requires informing the patient of what type of care you're going to provide, like what their condition is, what their possible options are, giving them the information they need to make that decision, with all knowledge that that they would need to make that decision. And so, I think in this case it would be the same. Like, the physician would have a duty to ensure that the patient has an understanding of what of all of those things, as it's kind of outlined in the bill. What is their diagnosis? What is their prognosis? What are their options for care? And so, if we're talking about a patient who speaks a language other than English and isn't going to understand that information if provided in English, then the physician would have a duty to get a translator or something like that before providing care to the patient, because the standards of care in the health professions would entail that the patient be informed of all of those things and be able to voluntarily and knowingly consent.
Chair, may I follow up?
Please.
Thank you. So that's I think that is exactly to my point, is that because if it's gonna be on the doctor's responsibility, and all they have is this legal form that is in statute that this is the words and these are in English, and then the patient who may not be able to comprehend and sign off on it, right? That could also create some challenges. So in terms of as we go along with these amendment, if you will, or some sort of, maybe it's in regulation, that we can think about how to do this from a much more less of a hardship standpoint, so that it's not coming from a doctor but coming from the patient.
Well, Eric Robbins, LCB Legal. One other thing for the record is, I will point out that the section about the form talks about it must be in substantially the following form, so it doesn't say that it has to be in exactly that form. And certainly, I think that if you had a patient who spoke a language other than English, that the wording of Section 25 would allow the form to be provided in that language.
And thank you, Assemblyman. Senator Edgar Flores, for the record, and for the sake of clarity, I'm more than comfortable in ensuring that we provide what we consider a friendly amendment to ensure that this information is provided in the language of the patient, so that the patient knows exactly what they're doing when they're filling this out. So I do appreciate your perspective, and I'll make sure we work on that.
Thank you.
And
Thank you, Senator.
Thank you to our legal.
Yes, thank you, legal team. Thank you, Chair.
And thank you, Mr. Robbins. I have 3 questions. Going forward, we still have up to an hour of public testimony that we will get to shortly. I will go next to Assemblywoman Gorlow, then Newby, then Thomas, and finish. All right, and we're adding 2 more onto that. All right, we'll start with Assemblywoman Gorlow. Please go ahead.
Thank you very much, Chair. I had a quick question regarding email I had received about there being a lawsuit in California regarding their legislation on the right to die. Are you familiar with that? As you can imagine, when I went to Google it, there were a lot of things that popped up when you put California and lawsuit in. So I was just curious if you knew anything about that. Thank you.
This is Dr. Koch, and do you know specifically what the issue was that was being brought up? I might be familiar with it.
I believe they were saying that it was against the constitutional rights that the email was referencing, and I was a little confused because I didn't see how this would be, so.
I'm not familiar with that, sorry.
That's okay. I get a lot of emails that don't have correct information, so I just wanted to double check, so thank you.
Thank you. Assemblywoman Newby.
Thank you, Madam Chairwoman, and thank you, Senator Flores, for bringing this bill. Dr. Koch, I think earlier in your discussions, you had mentioned that it's a very onerous process that has to be followed, and I appreciate all the safeguards. I'm just wondering, from an operational standpoint, I think back to when my mother was passing away, the idea of trying to get her to various doctor's appointments on certain time frames and such was nearly impossible for her and the amount of pain that she was in. So, how does that work for someone who is at the end of their life in a lot of pain to be going to all of these different appointments and trying to check all of the boxes if this is something that they want to do?
That very concern is what eliminates many patients from qualifying for medical aid in dying, is that they do not have the physical stamina or wherewithal to get to a doctor's office. Some doctors are willing to go to a patient's home to do those visits, and I am one of those if they are within a reasonable distance from my home. But some patients just don't have that option available to them because they are so ill. It's one of the reasons hospices try to have arrangements with providers who are willing to go into a home if they have a family that is seeking that out. And it's one of the reasons that many people will complete that process a little bit earlier in their disease course in order to ensure that they're able to, but then they don't request their medication be available to them until they are closer. They've just jumped through the hoops, so to speak, and then when they are ready, they request the medication if they choose to.
Thank you. Assemblywoman Thomas.
Good afternoon, and thank you, Madam Chair. And it's good to see Senator Flores back on the third floor. And I appreciate this presentation. Like my other colleagues, we've been receiving, I would say, thousands of emails regarding this particular subject. But earlier you had mentioned data, and you know, I kind of like data. And I was wondering if you could go back to Oregon, 25 years of data of maybe the abuses. Does it show that as far as the demographic, you know, with Black, brown, Asian, you know, if we can get those numbers, if you have them?
Sarah Mance for the record. Thank you, Assemblywoman. We have categories of data that show us that the patient who uses medical aid in dying is most likely to be white, to be 50s, 60s, or 70s, to be suffering from a terminal cancer diagnosis. When we try to go into detail in states, we get into a little bit of a difficult data problem in terms of determining what is the rate at which different groups may select this, because of some of the disparities in our system having to do with which demographic groups that are more likely to be dependent on Medicaid as well as Medicare at the end of life. And so for that reason, it's very difficult to know. But you had asked about abuses and yeah, thank you.
Thank you. Follow-up, Chair, please. Okay, and you know, we've heard some really controversial questions here today, like insurance, with assisted suicide, mental health, and lawsuits. So my question actually has to do with the death penalty. So it's kind of like assisted suicide by state. So I was wondering if this is a cocktail that the states use to terminate a life.
This is Dr. Koch for the record, and what a great question, no.
Thank you, I appreciate it. For the record.
Vastly different legal processes as well. I have two more questions left, and then we'll move on to testimony. I appreciate everybody hanging in there. It's been a long hearing. Assemblyman Hibbets, we'll start with you.
Thank you, Chair. Senator, good to see you. I have a question related to, well, what I believe is process. Forgive me, I'm going off of the latest version of the bill, so I haven't seen what it started out as. if you look at section 3, subsections 1 and 2, it talks about the coroner or coroner deputy. I'll just refer to it as coroner for the sake of brevity, conducting investigations. It says, not required to certify a cause of death in a patient who dies after self-administering. Subsection 2, any records, everything is accessible, blah, 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 which is all great until you get down to section 7. Except as otherwise provided in NRS 259 and section 6 of this act, the coroner shall immediately investigate the death and certify the cause of death. Then when you pop over to section 46.5, subsection 2 and, subsection 2, sub A and B. Coroner or coroner's deputy is informed or otherwise discovers that a person has self-administered medication pursuant to this, may make an appropriate investigation. Subsection B, must cease investigating the death after determining that the terminal condition with which the person was diagnosed resulted from a natural cause. So my first question related to this, is this the revised version after the concerns that were brought by Washoe and Clark County in the Senate hearing?
Thank you for that question. Senator Edgar Flores, for the record. The answer is yes. This is the revised version.
And as a follow-up to that, it's more of a statement, I would hate to see how complicated it was before this then. So my follow-up to that is, in 46.5 sub 2 sub B, why must they cease investigating? What are we hiding?
Thank you for that question, Assemblyman. Senator Edgar Flores, for the record. Just in general, there is a duty to investigate. And that's necessary because we want to make sure that whatever it states on here is in fact the reason. And what I'm trying to get at is there are scenarios where we've seen countless of stories where an individual said that they died of cause A, and then after an investigation realized, well, wait a minute, there's all these different things in their system. We think there may have been some foul play. It might have been cause D. So that's what they're usually trying to figure out, right? They're just trying to make sure that there isn't foul play. And that's why we work with them. And there's a whole host of other things that they were also trying to capture. But ultimately, that's something that happens now all the time. And what we are trying to make sure with that particular section that you quoted is saying that once they've in fact determined that that's what it was, and that's where we stop. In other words, we just want them to know that they understand that their investigation allows them to find out this is exactly what happened. Here's the cause of death. It was this terminal illness. There's medical aid in dying, and then they're done. But we still want them to be able to do that investigation and realize that that's what it was. If in that same exact investigation they were to find something completely different, and it wasn't medical aid in dying, something completely different, then obviously at that point there may be XYZ things that would take place, including maybe an investigation with law enforcement, et cetera. But that was part of some of the conversations that were happening with that, just to make that abundantly clear. And this language was done with them in conjunction, sitting down with us and explaining what they do and when they do it and why they do it. But Ms. Mans, did you want to add anything to that?
Thank you, Sarah Mans, for the record. The only thing I'd like to add is that this language was arrived at after lengthy conversations about what the obligations of coroners and investigators are. And their concern was that they did not want to be forbidden to determine that this death was after that prescription was issued. They did not want to also be required, as they would otherwise be by a different part of the code, to investigate the death so to determine that no crime had been committed. And they did not want to be required to do that simply because folks who have been through this whole process, the patient has gone through this whole thing and gotten this prescription and then used it, which, 2/3 of patients use the prescription, 1/3 of them don't. So among those, then, as you know, I believe you're retired law enforcement, is that correct? As you know very well, the process of investigating an unattended death is extensive. It has a lot of legal requirements for the coroner's department, and it can cause the family to have to go through an extensive process with, with the remains and all that. And so what they wanted to make sure was that they could do their duty and fulfill their obligations to the public, but that they would not be required to impose that on the grieving family in every instance of the use of this. So that's what that was for.
So, to clarify, if I'm understanding what you're saying, the coroner's offices, and I'm assuming we're talking about Wash and Clark Go, because that's who I have listed in my notes that had concerns during the Senate testimony, said that they wanted this language in here to have them stop investigating so that they didn't have to fill out a certificate of death that said either suicide, which legally this is what this is, or based upon the language of this bill, put something other than what it factually was. Is that what their concern was in needing this language in here?
I'm sorry, I wouldn't be able to answer that.
And I don't know, Senator Edgar Flores, for the record, I don't know if anybody from Clark or Washoe is here, but if they are not, we could also see if they're in the building. This was at their request. I think it'd be best if we could have them walk you methodically through their entire thought process, because it was 100% compromised through their request of what the language that they wanted on the back end. So I'll reach out to them, see if we can get them in here at some point prior to the hearing ending.
And I'm sorry, when you said that you were working on this language, was that with the lobbyists from the counties or from the actual coroner's representative?
For the record, Senator Edgar Flores, for the record, I think they were in consultation with their folks. It was with the lobbyists in the room, but they were in consultation with their folks.
Thank you very much, and thank you, Chair.
Thank you, and I'm going to encourage you guys to take that offline and follow up as you need to with the appropriate parties. I do not see anybody in here from Washoe or Clark's sheriff's offices or otherwise, so that follow-up would have to happen afterwards. One last final short question from Assemblywoman Gonzalez, and then we'll move into testimony. Please go ahead.
Thank you so much, Madam Chair. I really appreciate the indulgence. I had a question because there's been a lot of conversation about mental health in our youth. Do we know any data on the people that have utilized this and if they've had any mental health diagnoses along with their terminally ill diagnoses? And I bring that up because I think that there's decades of research that show that firearms account for more than 50% of suicides. And my colleagues, when we try to pass legislation to impact this, vote against it every single time. And what I'm struggling with is that there's no data that supports these arguments. And I just wanted to know if you could address that. Thank you.
I'm going to preface this with it. Again, we are not talking about mental health in general as a public and behavioral health issue, but if you would like to respond as it pertains to the bill, please go ahead.
Sarah Mance for the record.
We're going to continue on, but he can come back at his after he's done in the restroom. Please go ahead.
Sarah Mance for the record. I'm sorry, could you, yeah.
My question is, what is the data supporting the fear that people who experience mental health issues are going to be vulnerable to us, to this bill if it were to pass? Because the conversation amongst this bill has been that folks are worried that people who struggle with mental health are going to somehow be vulnerable to tactics that push them into choosing this option. And so I just wanted to be clear on the record what is that correlation? Thank you.
This is Dr. Koch for the record, and there is no correlation between mental illness and requesting assisted suicide. There is no correlation there. Mental illness that is leading to depression, that is leading to a desire to end one's life, is actually a contraindication if it's the mental illness driving the process. If it's a physical illness driving the process and that creates a life expectancy of 6 months or less, then that person qualifies, and their mental illness might not disqualify them, although it would complicate the approval process. Because it would be more important to separate their physical and mental illnesses. But someone with a mental illness does not have a life expectancy of 6 months or less, and therefore doesn't qualify. And just for the record, that actually does include somebody with anorexia, for example, unless they have reached an irreversible point of end organ damage, meaning their kidneys are failed, their heart has failed, and there is no coming back even with the best of care. At that point, that person becomes terminal, and then they could qualify. But that's really far down the road for that mental illness.
And Madam Chair, Senator Edgar Flores, for the record, I know that we are done with questions. I have a very lengthy agenda in my committee before Senate Government Affairs, and I know the governor's staff is waiting for me. I am being summoned back, but I will have our remarkable human beings that are experts in this area to remain for any additional questions that may be brought during opposition. But I do want to apologize ahead of time to all those testifying in support, opposition, and neutral, that they please do not think I am disrespecting them. But I do have the governor's staff waiting to present a bill, and they are presenting twice, and so they have a very short window to be able to do that in my committee and then the following committee. So out of respect to them and that we give them ample time for their hearing, I need to step out. I do thank everybody for your questions, and I thank you for your time. We're going to continue working on this bill, should there be anything else that I can do. And that includes even those of you who will not support the bill. I've amended the bill numerous times already, in the interest of having the best possible safeguards in place at the request of individuals who said they would not support the bill anyways. I am not looking to amend the bill to get you to agree with me. I am looking to amend the bill to ensure that we have the best possible safeguards in this legislation, so that we can ensure that we are taking care of the folk that we are concerned about, which is the most vulnerable populations in the state of Nevada, who are unfortunately have a terminal illness and are right now presently deciding between suffering or not. Thank you, Madam Chair.
Thank you for your time today, Senator Flores. And we know this time of year, it is a lot of back and forth between the houses. So we appreciate you being here today. And I believe we are at the end of questions anyways, so we are going to move into testimony at this time. I would ask the presenters to please take a seat in the audience, and we'll invite support testimony on the Senate Bill 239. We are going to start here in our physical locations. We'll take about 7 minutes of testimony here in Carson City, 7 minutes of testimony in Las Vegas, 7 minutes of testimony on the Zoom and phones, and then any that is not used during those other in those other locations, we'll come back around and make sure we catch as many as folks as we can. But we're going to start with that procession. So I have staff setting a timer so we have an accurate calculation of our time, and I would ask that you please state your name for the record before you begin. Begin when you're ready.
Good afternoon, honorable committee members. My name is Dr. Claire Johnson. I am an emergency medicine physician and live in Reno with my husband and daughter. As an ER doctor, I see a great number of patients suffer at the end of their lives. I see patients lose their ability to eat as stomach cancer takes over their bodies. I have seen men who are 6'2", weighing only 130 pounds as they finish chemotherapy. I'm relieved to know that we in Nevada are once again considering a bill that would honor the options of terminally ill people to decide how and when they die when death is inevitable. It has become evident to me, with great medical advances, we have created great suffering. We live longer, but often not better. I believe it is our moral imperative as a society to give options that alleviate this suffering. We have embraced hospice. We must go a step further by passing this bill. There's a common misconception that people die of natural and peaceful causes in the last 6 months of life. This is untrue. Some of us will die after days of dehydration and weeks of starvation as we lose our ability to swallow. That is how my father died in 2020 after a long illness. Some of us will die with severe pain, persistent vomiting, or air hunger. A coworker in California recently lost a family member after a 3-year battle with metastatic cancer. In the end, she couldn't eat and was completely bedbound. California fortunately had authorized medical aid in dying, so she died in the comfort of her own home with loved ones by her side. I ask you to please set aside your personal belief system and consider passing this bill. We owe it to the diverse population of Nevada to provide diverse options at the end of life. Thank you.
Thank you for your testimony. We're going to the middle seat. Please begin when you're ready.
Thank you. Good afternoon, Assemblywoman Peters and members of this committee. My name is Catherine Nielsen. I'm the Executive Director of the Nevada Governor's Council on Developmental Disabilities. I want to start with medical aid in dying is sometimes incorrectly referred to as assisted physician suicide, physician aid in dying, death with dignity, and euthanasia. Medical aid in dying is not assisted suicide or euthanasia. These terms are misleading and factually incorrect. Medical aid in dying protects patients, affords dying people autonomy and compassion during the most difficult time, improves end-of-life care, and would cost our state almost nothing to implement, except for the minimal costs associated with collecting data and producing the annual statistical reports. Our council supports the individual's right to make informed choices on decisions that will impact their life, and this includes their right to make end-of-life informed choices. Informed choices occur when a person, with or without reasonable accommodations, understands all of the options available to them, including the benefits and the risks of their decisions. The process of informed choice doesn't have an end and doesn't just occur at one time. Informed choice is part of an ongoing process of engaging people in person-centered conversations about their goals and decisions that will impact their life. An informed choice allows an individual with disabilities to be in control of their life's decisions and ensure they're making meaningful choices about what will impact their future. Our council believes that all people with intellectual and developmental disabilities should be provided with all options that impact their life, and if possible, should be provided the opportunity to experience and or explore their options before making such a decision. To save you guys some time today, our policy recommendations will be printed on our statement. Thank you.
Thank you. And when you are done, would you mind taking a seat back so that we can have more people come up to the table when you're ready? Yep. Thank you so much. Please go ahead.
Good afternoon, Chairwoman Peters and the brave committee. My name is Dora Martinez. I'm co-founder of the Nevada Disability Peer Action Coalition. I really must say I was really confused coming to this this hearing. Up to this, before you guys all came, I was sort of opposed, but hearing all of the debates, I am grateful for Senator Flores for giving us disabled people and those who are terminally ill have a choice. And I really sincerely hope that Assembly, I'm so sorry if I'm butchering your name, Wynn, who brought up the language, please include ASL, because ASL is not English. It's not English. As a person who is visually impaired and could be loose of hearing, I am learning English language, and you could do hand over hand if you all have seen Helen Keller. But I'm sorry, Madam Chair, if I'm going over time, I can't see your clock. But thank you so much.
We do not have a clock today, Ms. Martinez, so please continue with your story. We do have
I will be quick.
Yeah, please go ahead.
But thank you so much, and I ditto everybody that went before me. Thank you, and God bless you all.
It's very nice to see you in person, Ms. Martinez. Thank you so much for making the trek up here. We appreciate you being here. The assistant, yeah. But our friend. To clarify that statement, we do have a 7-minute timer going, but we are not timing individual testimony. We do just ask that you be thoughtful of the other people who would like to testify. So if there is an opportunity to say ditto, that you say ditto. Please proceed.
Good afternoon. My name is Rabbi Benjamin Zober. I was approached to speak on this issue to provide religious perspective. In Judaism, we believe that whatever God's role in death and dying is, human effort on the side of compassion is a moral act. It is not moral or compassionate to tell a person whose life is no longer a blessing but a curse that they should be experiencing joy in life and gratitude to God for keeping them alive, and that they only need to change their attitude. Now, I am not alone in this view. I've spoken with a number of my colleagues in a variety of locations throughout the state, in different religious communities. They stand with me today in recognizing the need for this bill. And as much as I would like to go on and talk about religious views, and believe you me, I have some really good rabbinic stories and some biblical highlights that support my position, this is not about finding the religious view, as there are more religious views than there are religions or religious people. It is about something else. There is a line in the Talmud, our collection of Jewish law, that says, "All is known, yet choice is given." Whether there is someone or something that indeed knows all is a matter of our respective religious views and our theologies. But the idea of choice being given to us is one that remains relevant and indeed is at the forefront of our liberties. Whether this bill is in alignment with our religious values is not the question that we should be asking. Indeed, every religion has its own opinion on that matter, if not several. But to adopt one of those views would be to privilege that religion and establish something outside of what our law allows. But what passage would mean is that people of this state have a choice in this matter, a choice that is not taken lightly. As has been said, there are many safeguards intended to make sure that this is only undertaken under very certain circumstances with every safeguard in place, and that no one who goes down this path does so lightly. But it is a choice, as is the privilege of a free person. People free to consult with their families, with themselves, with their religion, and, if need be, with God. If people's religious or moral beliefs cannot allow for this act, then they are not forced to take it, not forced to participate. But defeating this bill on grounds that it would violate one religion, or even a few, forces all to live by that standard. Forced standards are not liberty, not for those who would never even think of choosing this as an option, and not for those whose faith leads them to this choice as an act of moral compassion. Liberty demands that we have choices, even if not especially for the most difficult decisions of life and death. Thank you.
Thank you. We have reached 7 minutes up here. We will go to Las Vegas and come back up to here when we've gotten through Las Vegas and the phones, okay? I'm going to go to Las Vegas. Please remember to state your name for the record. You may begin when you're ready.
Good afternoon. My name is Patricia Gonzalez Portillo. I'm here to testify on behalf of Hannah Olivas, a 49-year-old mother who lives in Las Vegas. Unfortunately, Hannah's condition is deteriorating, and she is unable to be here today. I'm reading verbatim. In 2017, I was diagnosed with a rare form of blood cancer called multiple myeloma. This incurable disease has taken over my life since 2017. At the time, doctors gave me a 5-year prognosis. This end-of-life care option is more important to me than ever. I am relieved that once again, legislators are considering this compassionate bill that would honor the options of terminally ill Nevadans to decide how and when they die, when their death is inevitable. I was very disappointed when similar bills introduced in Nevada did not move forward during the 2019 and 2021 legislative sessions. At the time, I urged state lawmakers in Nevada and other states nationwide to pass these compassionate laws. But this rare and aggressive cancer has taken a toll on my body. I am not the same Hannah I was in 2021. God has given me one more opportunity to use my voice. I am tired. I am in pain. I am scared. I don't have the time or the energy to fight for this bill any longer. I am exhausted, mentally and physically. I am nauseous. I do not have much more time. My focus is to live my last day surrounded by my 4 children and 2 grandbabies. Terminally ill Nevadans are dying in pain and agony with no other options right now. Government or state agencies should not decide how much suffering is too much to bear at life's end or tell us how much pain is acceptable. No one should be able to tell me how I say my last goodbye. Honorable Nevada legislators, I urge you to put yourself in my shoes. I plead that you listen to my story. I am terrified that my right kidney is shutting down from all the treatment and progression of the disease. My body is badly broken as a whole. I do not want to leave my family with those horrific images as I die slowly in unbearable pain. I am tired of the endless hospital visit, CT scans, MRIs, PET scans, biopsies, and blood tests. I refuse to spend my last days connected to machines, catheters, and tubes that will cause more pain and vomiting that will only debilitate my body. When my Lord calls me, I want to die peacefully, surrounded by my husband and our sons and 2 daughters, and our precious grandbabies, Dominic and Damien, holding my hand in prayer. There are others like me who need this option now. I urge you to please help me pass this compassionate bill to make left what is left of my life and my death a peaceful one. Thank you.
Thank you. Thank you for sharing that story. Please remember to state your name for the record. You may proceed.
My name is Dan Diaz, and I'm actually reading somebody else's testimony as well. I'm reading on behalf of a friend of mine who cannot be here today because she is currently receiving medical care. This is her testimony. My name is Linda Brooks Bracey. I'm 57 years old, and I live in Las Vegas, Nevada. I am dying of metastatic pancreatic cancer. I am dying. Metastatic pancreatic cancer is killing me, and it will end my life. That's a hard fact, and that cannot be changed. But what can be changed is how much suffering I might have to endure. To have the option of medical aid in dying in Nevada would mean the world to me and to other terminally ill Nevadans who are in the same predicament. Since my initial diagnosis in February of 2021, I've undergone months of aggressive treatments, including chemotherapy, a major surgery that required months of recovery, and then additional rounds of chemo and a clinical trial. Yet still, my cancer came back with a vengeance very clearly. The doctors tell me we've done all we can do medically. I'm currently on palliative chemotherapy to manage my symptoms and potentially give me some more time. As a Christian, I am not afraid of where I'm going after I die. My personal faith is deeply rooted in a loving God. But what is unacceptable is dying in pain and leaving my children so early in their lives. It is unfair to force my family to watch me die in the kind of pain pancreatic cancer so often causes, especially when there is a safe option like medical aid in dying that so many other states offer their terminally ill individuals. Please support SB 239. Thank you, Linda Brooks Bracey. So now the reason that I am here is because my wife, her name was Brittany Menard. My wife, Brittany, died on November 1st of 2014. Brittany actually utilized medical aid in dying. So I can speak to this firsthand. I can speak to the safeguards. I can speak to what it takes to actually get that prescription. Brittany was only 29 years old and battling a brain tumor, but she was able to experience a gentle death only because of this option. Linda, here in Nevada, should have the same option, end-of-life option that Brittany had, period. The people of Nevada deserve better. They should not have to leave their homes just to ensure a gentle dying process. Thank you.
Thank you for sharing your stories. Next at the table, please. Thank you.
Good afternoon, honorable members of the Health and Human Services Committee. My name is Dar Stone, and I live in Las Vegas District 41, represented by Assemblymember Sandra Jarecki. I have been a physician assistant for 40 years, the last 25 years here in Southern Nevada, and prior to that, I was a registered nurse and commissioned officer with the United States Public Health Service. I would like to thank you for once again introducing this compassionate bill that would allow terminally ill adults the option to die peacefully. Throughout my career, I have stood bedside with patients and their families at the end of life, and it has too often been fraught with pain, suffering, and intense anxiety. These dying individuals want the option to ease their pain and suffering so they can die peacefully. I understand this decision is not for everyone. No one has to opt in to this decision. No patient, no physician, no pharmacist. It is a choice. It is important to clarify that medical aid in dying is not assisted suicide. It involves mentally capable people who request medication to be able to die peacefully in their own beds surrounded by their loved ones. People who request medical aid in dying are not depressed. They are not wanting to die. They simply want the option to ease their pain and suffering so they can die peacefully. It is not suicide. We should always provide quality end-of-life care for people who are suffering from an incurable and irreversible terminal illness. But when a person only has months, weeks, or even days to live, and there is nothing else that the world of medicine can offer, we should allow the person the option to end their pain and suffering when the time comes. For those concerned that this decision may be impulsive or coerced, these decisions have simply not, or these concerns rather, have simply not been borne out of the evidence gathered over the last 2 decades in states and Washington, D.C., where medical aid in dying has been legalized. There are strong safeguards in place in this bill to prevent abuse, coercion, and impulsivity. None of us who work in healthcare questions a patient's right to informed consent. It is the backbone of our virtually unanimous belief in patient autonomy, the right to elect or forego a medical intervention. This logic should extend to the rights of a patient to control the circumstances of their death. We're all going to die. The patient themselves and not the healthcare system should be in charge of their end-of-life decisions. It is simply humane and compassionate when suffering is refractory, when hospice care has done all it can do for a person suffering from an irreversible terminal illness, that the patient be allowed to ingest a medication to end their suffering if that's what they choose. Honorable legislators, I urge you to support this compassionate legislation that would allow terminally ill Nevadans the option to die peacefully and not painfully. Thank you very much.
Thank you. That testimony brought us to over 7 minutes in Las Vegas, so we're going to move to the phones, but if there are more folks who'd like to testify in support in Las Vegas, please come up to the table so that we can get an idea of how much testimony there is in support down there. BPS, we could go to the lines right now for testimony in support. Actually, I'm sorry. I'm going to check the Zoom first. BPS, if we have anyone on Zoom who'd like to testify in support, and then we can go to the phones.
If you would like to testify in support of Senate Bill 239, please raise your hand in Zoom to take your place in the call. Chair, there are no Zoom participants at this time.
Let's go ahead and go to the phones then for testimony in support of Senate Bill 239.
To testify in support of Senate Bill 239, please press *9 now to take your place in the queue.
Chair Peters, members of the committee, my name is Jeff Sugarman. I represent the Death with Dignity National Center, an Oregon-based organization that works on legislation across the country and serves to amplify the voices of terminally ill patients. We are in strong support of Senate Bill 239. I was the campaign director for the original Oregon Death with Dignity campaign in 1994. We sought to develop a process that ensured dying patients would have this option under a set of safeguards and a well-defined process. You have heard Senator Flores and others describe the many safeguards in this law, from the initial oral request to the self-administration of medication. What I can add is the following observations, having worked on this issue for over 2 decades. This law is rarely used. On average, less than 0.5% of deaths reported in all states can be attributed to medical aid in dying. There has never been a prescription written to anyone who did not have a diagnosis of a terminal disease within 6 months of death. Not once. No patient or medical professional has ever been forced into using this law. Both the safeguards and the opt-out provisions have worked, ensuring that there is no fraud or coercion and no one is forced to participate. In Oregon, in 2022, 91% of the people using this law were enrolled in hospice. 92% died at home, over 60% had cancer, and over 90% had health insurance. This law has worked. Under Senate Bill 239, you can be assured it will be used in Nevada with the same care, compassion, and caution as it has in all other 10 states where it is legal. Thank you.
Thank you for your testimony. Next caller, please.
I'm sorry, I picked the wrong side. I'm against.
Thank you. We'll move on to the next caller and put you back in the queue. Next caller, please, BPS.
Hello?
Hello, are you in support of a Senate Bill 239?
Yes, my name is Will Bradley of Las Vegas, and I do rise in support of Senate Bill 239. To give you some background, I am a pretty conservative Republican. I'm a graduate of a seminary as a Christian, and I'm a retired lieutenant colonel and combat veteran. I've had some experience on both sides of this, and after prayerfully considering this, I want to join the 80% of my fellow Nevadans in the latest poll in support of someone's right to choose their own death, knowing they're doing so out of compassion for themselves, number one, to put up with the amount of pain. I'll never forget the first time I investigated a suicide of a soldier in Iraq. And it didn't ring true to me at all. I've never had those thoughts, why this person would kill themselves. After investigating what was happening in their life, and they were under the care of a psychiatrist in the United States Army, this person chose to end their life with a 9mm shot to his head. I understand why he chose to end it, because it's logical, it's ethical, and it's moral, that if someone is in pain, that they have their own choice to end their pain. Whether you're a soldier going through whatever you're going through, or whether you're going through medical. Matter of fact, I'd like this extended, because we've all read lately 3 people in prison have even committed suicide. I'd like it extended to where if someone wants to avoid or end their torture in one of our state prisons, they can opt for this. I know it's not part of this bill, but there are people going through pain all over our state, and they don't have a reasonable way of ending their life. And if they choose to do it, they should have a right to do it. So again, I'm in support of this bill. Thank you.
Thank you. Next caller, please.
Hello, my name is Abad Pisa. Incurable, inevitable. These are words I've heard in several testimonies today. Pain, another one suffering. To feel pain is to know you're alive. Knowledge today is money. Let's not forget Bill 289, human composting or the death penalty. My sister was a U.S. National Guardswoman. I feel she was lied to because when she got cancer and she was only given weeks to live, we were able to get my sister out of the country to find her a cure or to seek alternative care, only to come back after she was cured to be arrested and held or forced to do chemotherapy. She was basically forced to die here, all because doctors' knowledge was negligent of ancient medicine or holistic medicine. Now, I don't want to be against people's choices, but when the law, in a sense, dictates how people can seek medical attention and possibly cure themselves of some ailments, I find it horrific that an option would be death given to that person. Because as I mentioned before, to feel pain is to know you're alive. Now, I don't oppose some people's opinions of wanting to end their life due to the pain and the suffering that they're going through. But again, knowledge, whether it's coming from someone we trust, someone we admire, or someone we may not know, can always hold keys that are valuable. With that, I end my testimony. But again, I will not oppose this. I am for it. Thank you.
Thank you for your testimony. Based on the context of the testimony, I'm going to put that into the opposition category, but appreciate the narrative, and we will add that time back into the support testimony today. So, BPS, are there other callers on the line in support of Senate Bill 239?
Yes.
Please add the next caller.
Caller with the last digits 458, please press *6 to unmute your phone.
Hi, good afternoon, committee members. My name is Laura Gray. I'm from Las Vegas, Nevada. June will mark the 30-year anniversary of my father, Roy Gray's death. His death certificate indicated he died as a result of the cancer he struggled with for months. In reality, he died as a result of dehydration and starvation. My father was unable to eat or drink in the final week of his life. During that week, my father constantly writhed in pain and discomfort. Eventually, his nurse urged us to start administering morphine to make him, quote unquote, comfortable. My family and I knew this would mean we would no longer be able to communicate with my dad, and this was true. I certainly wouldn't refer to my father's morphine haze as comfortable. He was simply incapacitated. The only thing my father responded to after administering his morphine was when his adult children changed his diapers. He would grimace in agony as if we were violating his very pride. Could you imagine this being one of your final experiences in life? We sat with my father, ironically praying for our loved one to die. We anxiously watched for the signs that would indicate his passing was near. Discolored nail beds, changes in his extremities, and the dreaded death rattle. If you've never witnessed death rattle, it is the most horrendous state for a human being to be in. It is like a very old car running in the heat, desperately trying to get to its final destination. I support SB 239 because if I were to become terminally ill, I would not want to endure the suffering and horror that was forced upon my father. I would also most certainly not want my loved ones to endure the experience either. But more importantly, I want this bill passed so that anyone out there facing the consequence of a terminal illness can choose to end their life peacefully and on their own terms. Thank you for listening to our stories today. I know they're difficult to hear, but they are certainly even harder to witness and to endure. Thank you for your consideration.
Thank you for your testimony. And seeing that there are many more folks who would like to testify in support, we're going to come back around to the folks who are at the table currently, move into opposition testimony, give them the same amount of time, and then see where we're at, and we will likely come back around for another round of support, opposition, neutral testimony after that. So I will go from the phones back here to Carson City. We'll take these three folks, go to Las Vegas, and take the last person at the table in Las Vegas, and then move into opposition testimony. Please proceed when you're ready.
Good afternoon, Chair and members of the committee. My name is Vanessa Dunn, V-A-N-E-S-S-A-D-U-N-N. I am here on behalf of the Nevada Public Health Association, also known as NPHA. NPHA follows the guidance of the American Public Health Association on this topic and is in support of SB 239, which will expand the options of dying and suffering patients in Nevada at the end of life. Thank you for your consideration.
Thank you. Please go ahead.
Hello, and thank you for taking time to hear me today. My name is Carrie Roussel, and within the last 5 years, I have been bedside with two very close family members of my own who both succumbed to death from cancer. One had the option of medical aid in dying, and the other did not. My aunt lived in California, and she suffered so much pain in her last weeks of life that she chose to stop and be done and make a decision of when to end her life. We gathered around her and we ordered in sushi and we cheersed cocktails and we sang songs and we talked about all the things that we needed to talk about. And then we gathered around her and we cheers with Dom Perignon. And when she handed her champagne glass to me and we handed her her cocktail, her final cocktail, she also made a joke about it and kind of stirred it with that big thick straw and said, "Whew, it's chunky," and took her last sip of her final cocktail. And she looked at us and raised her glass, and then she shut her eyes and gently fell asleep, and she was gone within minutes. And it was easy, and it was right, and it was not difficult. And the family and friends that surrounded her bed at that time looked at each other, and we knew that we did the right thing. It was not easy, but it was not difficult to choose this path. And she lifted off with light, surrounded by her family members, and she left us in a gentle, really right way. And then about a year later, I lost my best friend to cancer. She was 36, and she was here local, and she didn't have the choice to use medical aid in dying. And she didn't speak to us in her final 3 days. And when she finally went, she suffocated in liquids that were filling up her lungs, and she really kind of sunk into the muck, and it was anything but light and right. It was deep, and it was dark, and it was difficult. And being there for both of those experiences showed just how opposite they were. One was light and easy and respectful and compassionate, and the other was not. And giving Nevadans this option, this choice, is truly the compassionate choice to make and is the right thing to do. I've seen it both ways, and I will always make the choice to choose medical aid in dying. Thank you.
Thank you. Please go ahead.
Good afternoon, honorable members of the Assembly Health and Human Services Committee. My name is Kim Mazeras. I am a retired executive from the utility industry, having lived in northern Nevada for over 40 years. My husband, Steve, loved life. He was a determined, intelligent, and caring man, a devoted father and grandfather, a veteran who late in life went to law school, spending the best days of his career at the Washoe County District Attorney's Office as a prosecutor. Our wonderful marriage of 30 years took a drastic turn in 2017. Steve was in his 50s when doctors initially diagnosed him with COPD. He spent years without disruptive symptoms until the spring of 2017, when he had a life-threatening exacerbation event. Steve's best hope was a lung transplant, which he opted for. He did well for a year, but something kicked off chronic rejection, and it was continually harder for him to breathe. But he continued treatments that could stop that rejection. During this entire process, Steve wanted the option to decide when enough was enough. We had numerous conversations about his end-of-life wishes, including a potential move to Oregon to access the state's Death with Dignity Act. I was really angry about the idea of uprooting ourselves to establish residency in a state where we have no family, a place that wasn't home for either of us. I don't know if Steve would have ultimately used the medication to die peacefully, but simply having had it as an alternative in our hands would have eased both of our minds and lessened the stress and fear of his pain and suffering. Steve's last 24 hours were horrific. He was in a tremendous amount of pain, and I scrambled to get him enrolled in hospice, because remember, we were still fighting at that point. His pain was unbearable without a more serious opioid. They let us know they could apply a fentanyl patch, but it was likely that he may not wake up once it was applied. Steve understood and agreed to move forward. Less than 5 hours later, my husband of 30 years took his last breath with that death rattle that somebody talked about earlier on June 9th, 2020. Honorable legislators, I urge you to support the End of Life Options Act so terminally ill Nevadans have the option to shorten their suffering at the end of their lives. I wish my husband would have had that option. Thank you.
Thank you for your testimony and sharing your story. We'll go to Las Vegas. Please remember to state your name for the record.
Madam, excuse me, Madam Chair, committee members, my name is Jana Wright. I'm a resident of Las Vegas, Nevada, and I'm speaking in strong support of SB 239. I would just like to say ditto to all the comments that have been made in support, and would like to thank Senator Flores, Dr. Koch, and Sarah Mans for their thoughtful presentation. And I urge the committee to support this bill and get it on the governor's desk. Thank you.
Thank you. So we are done with our first round of support testimony. That was 38 minutes total, with no limit on individual speaking time. I realize we've had some folks move up to the front, but because of the hour, I'm going to ask, is there anybody in here who has to leave in the next 30 minutes who would like to get up here first? But okay, I just wanted to make sure that we were, because we've been here for a long time, wanted to make sure that we were accommodating people if they needed to leave. Please remember to state your name for the record. For the record, we are going into opposition testimony on Senate Bill 239. We are starting here in Carson City. We will do about 7 minutes in Carson City. We'll go to Las Vegas, do about 7 minutes in Las Vegas. We'll go to Zoom and the phones for about 7 minutes, and we'll round it out similar to how we did with the support testimony. So please go ahead when you're ready.
Thank you, Madam Chair. For the record, my name is Herb Santos, Jr. I oppose SB 239 because I'm scared, not for myself, but for my children and my grandchildren, because they will be the ones whose health care will be in danger if this bill passes. I'm also scared for the vulnerable, the elderly, and the disabled. In fact, I fear for everyone in this room, your children, your grandchildren, your nieces and nephews, because they will all be the ones whose health care will be in danger if this bill passes. If passed, you will be giving insurance companies a direct path to profits over people. Insurers will deny expensive, life-sustaining medical treatment and in their place offer lethal drugs, leading patients to hasten their own deaths. If passed, this bill will threaten the health care of every single person in this state. You may have heard the proponents represent that there is no evidence of this type of abuse. That is a blatant and offensive misrepresentation to this body and to those who have been victimized. People like Barbara Wagner. Senator Stone mentioned Ms. Wagner during the Senate committee hearings. She was denied treatment and offered a suicide prescription. The response from the proponents was that it was sad, but that is what insurance companies do. They deny all the time. In 2019, the National Council on Disability released the findings of a federal examination of the country's assisted suicide laws and their effects on people with disabilities. They found that the law's safeguards are ineffective and oversight of abuses and mistakes are absent. I'm also scared for the quality of care my children and grandchildren will receive if assisted suicide becomes medical treatment. Catherine Judson learned this in Oregon when she brought her husband to the doctor for treatment, and she overheard the doctor giving a sales pitch for assisted suicide. Any benefit of assisted suicide does not outweigh the harm this bill will cause on all Nevadans. Now, I've submitted a more detailed written opposition, and I ask that you review it with all the supporting data. I'd also like to add, from listening to the testimony today, talking about psychological consults, that's not the norm. Since this started, in looking at the Oregon study, and they do a study every year, there was 431 people that requested assisted suicide last year. 3 people received psychological counseling. When you look at the inception of the 2,454 people that have taken the lethal drugs, 74 people took it, which is 3%. 3% of the people were referred for psychiatric counseling. And that goes from 1998 up through 2020, and that's in their statistics. There was also a comment that there's no evidence of a person ever waking up. In the documents I've submitted to you, there's a story of Mr. Pruitt, David Pruitt. He took the cocktail, and it was with his family was there, along with members of Compassion and Choices. And after 65 hours, he woke up, and the Oregon Department said that they couldn't investigate it. Finally, in my legal practice, some of you know I do workers' comp in the state. I've been doing it for over 30 years. This happens all the time with insurance companies denying treatment to people that have been injured on the job, and that's what happened. And that's what will happen if this law is passed. In conclusion, SB 239 is bad law, and I respectfully request that you vote no, not only for your constituents, but for your children, their children, and the majority of people in Nevada. Thank you.
I just got a notice that we have someone on Zoom who has been waiting patiently for opposition who has to leave. So I would like to go to Zoom next to include her in the testimony. So BPS, if we could go to Ms. Hammond on Zoom to provide her testimony in opposition.
One moment, Chair. Chair, I am trying to communicate with our Zoom guest, and we are having difficulty getting them to turn their camera on. Would you like to move on until I'm able to get that addressed?
Yes, will you please? Oh, there she is. Hello, Ms. Hammond. Thank you so much for being here, and I apologize for the delay in your opportunity to speak. Please go ahead when you're ready. You are on mute. If we can't hear you, if we could turn that mute off. Ms. Hammond, you are still on mute on your end, it looks like, if we could get that to turn off. Oh, there we go. Please go ahead.
Yeah. My name is Diana Hammond. I am an international disability advocate born and raised here in Nevada speaking in opposition. Please note, I have an impaired bill cannot be cured or modified by any current medical therapy or treatment. In fact, I have several. They are called disabilities. The reading of the bill clearly does not say the word disability. All you need is a criminal doctor to make a subjective pronouncement of my imminent death, which many would be very willing to do. Then I meet the definition of terminally ill. I'm amazingly healthy, but I am at risk here. All ideas, including assisted suicide, are utopian, full of safeguards and happy, rich white people who are used to having control over their health care. But reality is chaotically haphazard and even violent, especially for people with disabilities and the elderly who live in poverty and even middle incomes. People with disabilities very often do not even receive suicide prevention counseling for depression. Did you know that? We show signs of wanting to give up or have suicidal thoughts, attitudes, and access barriers can make us lonely, but no one tells us about counseling. They tell us about death. What kind of message is that? Disability you are born with is just you are. I do not want to be you. I want to be me. Disability at all. And for people who acquire disability, we are talking about conscious, sentient human beings who need time to adjust to limitations and overcome obstacles. Assisted suicides push fails to allow that time. I need you to understand that the only alternative to death that doesn't power for people who require assistance is poverty and segregation in nursing homes. Then it makes no sense to talk about assisted suicide as a choice. Because according to the Oregon statistics, the number one reason that people choose assisted suicide is not wanting to be a burden. No one even tells them about attendant support and all the other myriad of supports that help us stay connected to community. I think it may be hard for you to imagine what it is like to seek medical services as a person with a disability. I have a very hard time getting many medical professionals to listen to me. It is like they have a script in their head about the poor disabled girl, and they assume they need to make decisions for me. I explained to a doctor that I had a significant gag reflex and would need sedation for a procedure, but he kept interrupting and assuring my mother I was not a behavior problem. Many professionals are as uncomfortable around me as the general public because they have the Stevie Wonder head on. People prefer to talk to the people I am with who have an easier time making eye contact. Family members have so much influence in the medical field, and not all of them want what you want. Well, meaning doctors look at me and think I would be better off dead. They will think it's a favor to offer to suicide me. Over and over again, I will be educated about my right to die. Do you know what it is like to be told you should suicide? You should fill out paperwork to end treatment. You should have a DNR. Everyone wants to educate me. No one wants to tell me my life is worth living. If you pass this bill, you make it law. You make it worse. If the death penalty makes racism and errors in the legal system permanent, then assisted suicide makes ableism and errors of the medical system permanent. You can't have it both ways. Did you know that children whose parent commit suicide are 3 times more likely to commit suicide themselves? and are more likely to struggle with depression. So if this bill passes, and I call the suicide hotline to say I'm depressed because Medicare won't approve a new wheelchair for my attendant quit, are they going to ask me if my state has an assisted suicide option?
Yeah. Done. I'm done.
Thank you, Ms. Hammond. And I would ask that if you have your statement in writing, that you send it in so that folks can read through it. We had some struggle hearing you at the very beginning and through portions of your testimony. Thank you so much for being here. And
I didn't video.
sorry, say that again.
She's sending a video.
Okay, thank you.
Right. She doesn't have to.
Yeah.
Okay, we're going to move on to the folks in Carson City. Thank you again, Ms. Hammond. Please go ahead when you're ready.
Thank you, Madam Chair and legislators. My name is Leslie Quinn, and I oppose SB 239. My brother fought non-Hodgkin's cancer for 10 years. Throughout those years, we were told many, many times his end time had come. Thankfully, he'd get better with treatments at the City of Hope. He'd have more time to impact his children's lives, to never give up. He'd tell them, give full effort. My brother fought for life for himself, his wife, and especially his children. He taught them that life is a gift, and only God can give it or take it away. 2 years ago, my pop passed. He lived in excruciating pain daily from various health issues. He refused meds to maintain his life. Before he did this, he canceled his life insurance policy, so there was no payout. He wanted no line in how he passed or false life insurance payouts. He died as he served in the Korean War, courageously and with honor. Okay. SB 239 requires coroners, doctors, etc. to lie on death certificates as shown on page 5, lines 26 through 30. Thank you. We already have DNRs and advance directives. If passed, SB 239 will raise life insurance premiums from the abuse and fraud of paid out policies. What about ADA or any patient that can't administer the shot to themselves or the drink because they are too weak or physiologically unable to? Who then administers them the shot or the drink, or what are the ramifications to that person who gives that to them? I'm definitely for death with dignity, thus the DNR and advance directive statutes. However, this bill opens up too much abuse and fraud. Last year, my best friend of 33 years passed from pancreatic cancer and multiple sclerosis and a boatload of other health issues. Regardless of her extreme pain, she chose life and letting God choose when her last day would be. I oppose SB 239 and ask my Assemblywoman Brittany Miller and Senator Marilyn Dondero Loop, as well as all the legislators here, to oppose SB 239 as well. Thank you.
Thank you. Please proceed.
Hi, thank you for listening to us. My name is Katrin Ivanov, aka Mrs. Fixit, Assembly District 42, Senate District 9. And I am opposing this bill for many reasons. People that spoke for the bill were talking about informed choice. After 2 years of involuntary house arrest in which we did not have choice, after coming up with some kind of a concoction that was not tested, that was mandatory for us to keep our jobs, we have to pick between some kind of medical intervention or keeping jobs and feeding our own kids.
I'm going to ask that you connect that to the bill.
Yes, it is connected to the bill.
Okay,
informed
please.
choice. This was not. We were not given informed choice. Not to mention
but we're
how
not
many
talking
times.
about the COVID pandemic. We're talking about the bill at hand. So let's keep it to the bill at hand, please.
Yes, but that was medical establishment plus legislatures plus government employees. Governors and whatever, people that we put in charge to help us, they didn't. They weren't making informed choices. They were making choices scared not to lose their positions. And people in these positions put us in this predicament. It is connected because we were not given informed choice. And also, there are also other things that people don't want to talk about, but there is a lot of elderly people that are rich and their family want them to die so they can take the money. Who's going to prove that they wanted to die? This bill is open to so many bad ways of using it, including the senator asked several times, what are the safeguards? There were several people came in here in testimony saying, the bill is full of safeguards, the bill is full of safeguards. But then when the presenter of the bill were asked, what are the safeguards, they didn't answer. They were asked second time, maybe they misunderstood the question, what are the safeguards? They said, there is no safeguards. So I don't know where the other people that were testifying heard the safeguards from or read about safeguards, but there is no much safeguards in the bill. This bill is open for a lot of bad way of using it, and I'm really hoping that you're not going to allow that to pass. We have so many problems in this state. Helping people kill themselves should not be a priority. People can kill themselves anytime they want to. They don't need a bill for that. I'm sorry to be blunt, but this is the reality of the situation. Thank you so much for listening to us, and thank you for the hard work you're doing. I know you're trying your best. Please don't pass that bill.
Thank you for your testimony. We have reached 7 minutes here. I'm going to take Mr. Cole since you were at the table there. We'll move on to, okay. Mr. Cole Dr. Cole has suggested we move down to Las Vegas. Since we're up for our 7 minutes up here in Carson City, we'll come back around like we did with support, but I'd like to make sure we have equal opportunities for folks on different platforms. In Las Vegas, please remember to state your name for the record. You may begin when you're ready.
Thank you, Chairman Peters and members of the committee. My name is Jill Douglas. I am submitting my testimony in opposition to Senate Bill 239. According to our Nellis website, public opinion on this bill shows that 64% are opposed and 34% support. I am one of those that oppose this bill as written. Life and death decisions are very difficult. This bill establishes troubling provisions governing the prescribing, dispensing, and administration of medication designed to end the life of a patient. I am extremely sensitive to those receiving a terminal diagnosis. However, I do remain concerned about abuses that will and can occur. Greed of heirs is real, spousal abuse is real, and elderly abuse is real. Not everybody is surrounded by a normal functioning family unit. I would ask people to read the exhibit submitted by Dr. Brian Callister. He is very articulate in his reasoning to oppose the bill. One of the things that he testifies about is that medical literature shows that the average margin of error in terminal diagnosis is 50 to 70%. So I encourage everyone to read his article and his testimony. As existing law already authorizes a patient with a terminal condition to refuse life-sustaining treatments, and hospice care today assists patients with a pain-free and pain-controlled death with dignity, both in-home and in facilities. I am concerned with numerous provisions, especially those that relate to self-administration of the medication to end one's life. I question how we would possibly know that, in fact, it was self-administered. I would think that a change in the provision that would allow supervision would be important. I am concerned about the requirements that you can request a prescription, and that would be done supposedly not under coercion, deception, or undue influence, but really, again, how could we know or measure that? There are many, many people who would be coerced and would be under undue influence. There's no way to measure that. It does create opportunity for abuse. Section 23 requires that a patient be advised of their right, that they have the right to revoke a request. But again, I'm confused by that, because if I request to have a prescription filled, how quickly is that filled? And so what really would be the time frame if I already have the medication? How would I be revoking that? And then I'm concerned that there's medication just sitting around people's houses until they maybe decide to administer it. Section 32 establishes a requirement for disposal of the unused drug, so I'm concerned as to why there would be an unused amount of the drug, and again, how would that be enforced? Sections 48 and 49 have to do with the prohibitions on life insurance companies, and I'm very concerned because you're saying that life insurance companies cannot enforce their legal contract, which has a 2-year suicide clause that would in fact cause life insurance premiums to increase. Finally, I am opposed to death certificates falsely not listing the actual cause of death. Death certificates must always accurately reflect the cause of death. So I ask that we protect the sick, the elderly, the disabled, and the depressed among us. Do not let us become like Oregon and California, where patients are pushed towards an assisted suicide over medical care. Please vote no on SB 239.
Thank you. Next caller, please, or next person in Las Vegas, please.
Good afternoon. I'm Susan Proffitt, Proffitt. I'm the Vice President of the Nevada Republican Club. And before I tell you a story about my own family's experience, which is very pertinent to this, I'd like to read a part of a letter from a professional who has had to deal with the emotional aspects of assisted death. Madam Chair and members of the committee, my name is Rowena Harrison. I have been a hospice nurse in Washoe County since 2008. Currently, my position is also working in pediatric hospice. Bill SB 329 to allow physicians, assistants, advanced practice registered nurses to prescribe medication to end a person's life is a dangerous bill to pass. This bill puts healthcare workers in a position of decision making that is not in our training nor ethics to assist a patient to end their life. And she goes on to talk about other available ways, but then she mentioned something else I think we need to add to this bill, because really I'm not completely opposed to it. We need to fix it, and we need the service, but not in its present form. She also says, I would like to help you understand the pressure that is put on healthcare providers is unparalleled, having to provide a lethal prescription dose to a patient who they've been caring for. This also puts families into interpersonal relationships at odds when one of the partners doesn't agree. And so I'd like to suggest that if you're going to be requiring a mental health evaluations, that also the people that are involved around them, that are administering them, that are dealing with the emotional aspects of having cared for them, they have the special training and the support that they need from our professional mental facilities. Anyway, that's, excuse me, my thing was messed up here. All right, here we go. And this is my story. I oppose it as it's written because it will do more harm than good in its present form. I too want to die as I choose, and my husband, who is dying of lung cancer, does too. But we don't want anyone else making that decision or anyone to put undue influence on us in our moment of pain and despair. First of all, I don't think it is necessary because we already have DNRs and advanced directives that offer us an ability to die in dignity. On the surface, this bill sounds reasonable, and will save the families from having to endure watching their loved ones pass very slowly. But it opens up a lot of opportunity for fraud, and even people that are hacking our computers can find a way in no matter what we do to fix it, and I think the crooks can find a way to get what they want with regards to moving some people out of their way too. In my case, our father was admitted to the hospital 3 times over 3 years, and each time I was told by my siblings that he was in his last phase of dying, that his kidneys were going. Yet each time he rallied within hours after being hooked up to an IV. That's all it required. So the second time it happened, they were able to bring in family services to keep it from happening again, and he passed away a year after that. But there was no reason for him to die other than my sister and brother were tired of waiting for their inheritance, and my sister was tired of taking care of him. And it was really unfortunate. And then there is this other situation where this bill, the only one of its kind that the Democrat legislature has brought before us this season pertaining to death, I would think, okay, it's okay. But this is not just the only bill that regards to death. One bill changes our driver's license to automatically donate our organs if we do not know that we need to opt out, because now we're automatically donors the minute we get a driver's license. And another bill makes it legal for the medical staff to harvest our organs if our family members are too far away to get there to tell them what they want for us, or what our wishes were, before the organs are too old to harvest. And so that's kind of troubling.
We have reached 7 minutes in Las Vegas at this moment, and I don't want to cut folks off, but we do have several other people who'd like to testify. So,
all right, may I finish here? I will address the bottom line. You all have been micromanaging your constituents in every one of these bills, especially this one. And I believe we need to make it absolutely sure that there is oversight, and there is, without a doubt, this is being done for the right reasons, because it's not just an inconvenient truth. It is the truth. People do have their own agendas. And, with all of these harvesting bills in here, it seems to me that somebody's looking to control the population and make a little money on the side with harvesting all of these organs and tissues, pretty much like Planned Parenthood does, while we pay for their overhead. So
all right,
I really wish you would redo this bill.
Person,
Thank you.
please. Thank you. Next person in Las Vegas, please go ahead. And because we're at 7 minutes, I'm going to take the two of you, and then we'll move to the phones and keep going with opposition testimony.
Okay, I'm Michael Plummer. I'm a practicing physician, a hospice physician with more than 50 years of experience as an anesthesiologist and now as a hospice physician. The question is, do we need this law? My answer is emphatically no. We do, however, listening to the stories today, we do need a lot of improvement in provision of hospice care and in provision of pain relief. As an expert in both of those, I think there are some F grades out there. Why do we think that patient care in Nevada will be improved if doctors are able to help kill their patients rather than curing them? Nevada already has in place the infrastructure to honor all citizens at the end of life. We can relieve pain, manage symptoms, maintain dignity in the face of loss of function. We can care for the dying with love and compassion. We do not need to kill patients in order to move things along and make things better. Nevada is actually targeted this year, along with a number of other states, by a powerful lobbying group with a fairly relaxed relationship with the truth. This group's MO is to introduce an identical law, a 30-year-old identical law, that's made to look as though it has stringent safeguards. We've heard lots of conversation about that today. In reality, all this law does is protect a doctor from charges of homicide if he helps you kill yourself. The group does very smart lobbying work to get the law approved in the state, and then, we don't know this yet, it acts as guardian of the law ever thereafter, making sure that the law does not change without their approval. They decide who dies and what lethal mix, make sure that no state ever gathers meaningful information because of the way the law is set up. They gather their own statistics, they trade their own recipes for death drugs. They have virtually no actual state oversight. They know that information is power. They gather all the information about the deaths in which they are involved, which pretty quickly is virtually all the deaths in the state. And the lobbying group over time becomes a powerful and shadowy dispenser of death, free of any government regulation. So I would say assisted suicide is not medical care. Not every activity that involves doctors and drugs is medical care. This is most surely not, despite attempts to dress it up and disguise it, not medical care. Assisted suicide, death from the doctor. Thank you.
Thank you.
My
Please
name
go
is
ahead.
Maggie Cecil. I'm a resident of Las Vegas, and I'm here to testify against SB 239. My mom, who died in May of 2020, just about 2 months shy of her 99th birthday, was a staunch supporter of the philosophies espoused by the Death with Dignity crowd. She explored end-of-life options presented by the Hemlock Society and made it crystal clear she would not live being dependent on anyone, including any of her 4 children. She even moved in her mid-80s to Oregon, believing that she would be able to implement plans to end her own life if she lived in a state where the right to die was legal. Her fierce insistence that she would take her own life rather than become dependent had gradually and completely dissipated by the time our family moved from Southern California to Las Vegas. Eager to be part of the adventure, and despite some evidence of dementia, Mom moved with us. If it didn't work out, we figured she could be in memory care in Las Vegas as easily as she could be in SoCal, though that proved to be unnecessary. She loved being with her family, and we loved having her. The 6 months her hospice doctor had predicted she wouldn't live past stretched into a year and a half, during which we had a major family reunion. She was able to reconnect with several relatives during the reunion, and a couple of special friends came to visit and spend time with her. She died at home in her own room, her beloved cat purring beside her. Her situation illuminates some of the risks to people unable to comprehend or authorize wishes they previously expressed. In this case, obtaining medication from a doctor for the sole purpose of committing suicide. At one time, Mom believed her suicide would prevent burdening any of her kids or losing control of her destiny. Turns out, she didn't need a doctor's prescription to kill herself. Hospice and palliative care available to everybody right now without SB 239 enabled her to die peacefully and on her own terms. Thank you.
Thank you. We're going to go ahead and move to the phones for 7 minutes on the phones and Zoom. We took Ms. Hammond early, so we will. I will take 3 minutes off of the time for phones for that testimony. BPS, can you check either? I believe Ms. Hammond was the only person on Zoom, but both Zoom and the phones for opposition testimony to Senate Bill 239.
To testify in opposition to Senate Bill 239, please press *9 or raise your hand in Zoom to take your place in the queue.
Good evening, Chair Peters and committee. My name is Jim DeGraffenreid. I'm Nevada's Republican National Committeeman in opposition to SB 239 on behalf of the Nevada Republican Party. Our platform states that we affirm the inherent dignity of each human being from conception to natural death, and we oppose assisted suicide, euthanasia, and the non-consensual withholding of medical treatment resulting in serious injury or death. I'd like to explain further why the words non-consensual are there. Republicans believe very strongly in liberty, the freedom of individuals to make their own decisions, up to the point where those decisions infringe on the rights and liberties of others. Some want us to view SB 239 through a lens of liberty, as its nominal goal is to allow each individual the freedom to decide for themselves how their life will end. Unfortunately, however, as with most situations where man tries to play God, it gets very complicated. And in this bill, the goal of allowing end-of-life patients to determine their own destiny runs headlong into the insurance industry and the government. You see, only a few very wealthy individuals have true freedom to make their own end-of-life decisions. They have that freedom only because they pay out of their own pocket for their medical care. For the rest of us who have to rely on our insurance plans or Medicare to pay for us, we are at their mercy. If SB 239 passes, it is in their best interest to encourage patients to end their lives rather than continue to live and consume insurance company profits or government funds. Anytime you ask someone else to pay for something you need, you give that person or entity the power to say yes or no. And as an insurance professional who helps people with their health care plans, I know that SB 239 is a dangerous bill for any patient who can't pay their own medical bills. Supporters say that this doesn't happen, but nobody can honestly say that because anyone who's been coerced into this decision is already dead and cannot speak up. It is up to us to protect those who have no voice. I strongly urge this committee to resist the false freedom that this bill promises and protect vulnerable end-of-life patients from the very real dangers of SB 239. Thank you.
Thank you. Next caller, please.
Caller with the last digit 607, please press *6 to unmute your phone.
Hello, my name is Michael Ryan, M-I-C-H-A-E-L-R-Y.
Ooh, we cannot hear you, sir. I don't know if it's maybe moving the mic closer to your mouth, but we cannot hear you.
Okay, is that better?
Yes, much better. Thank you. Please go ahead.
Okay, very good. Thank you. Yeah, my name is Michael Ryan, M-I-C-H-A-E-L-R-Y-A-N. I'm a longtime resident of Nevada and a Marine Corps veteran. I'm calling in to vote to express voting no on SB 239, assisted suicide. Respect life, protect the vulnerable, the old, the disabled, and the depressed. SB 239 is a horrible bill. Please vote no. Thank you very much.
Thank you. We are at, I believe, 7 minutes on the phone. I will take one more caller before we do another round. And so, BPS, could you add the next caller, please?
Can you hear me?
We can. Please state
can you hear me?
and spell your name for the record.
Yep.
You may begin.
Thank you. My name is Heather Arshenko, A-R-E-S-H-E-N-K-O. I'm a mother. I'm a chronic illness patient. I also work in healthcare. I have worked in hospice. I have a degenerative and progressive neurological disease that impacts my central nervous system. In 2018, after having a severe relapse and progression of my disease, I was told by my specialist physician that I should get my affairs in order and it would not be long before I was in need of full-time care. I have feared in the past that I was a burden to my family. Instead of following that dark path that doctors prescribed to me, I went against medical advice. I joined a patient-funded clinical trial that I found independently of my doctor, who was under financial incentive not to tell me about all of my options, and I've testified about this previously to this committee in previous legislative sessions. And eventually, through therapeutic rehabilitation and a long recovery, I restored my function, I healed parts of my brain and spine. I am an active mother. I am working in gainful employment. I am able to advocate for myself, my child, and my community and families with disabilities because I am alive today. As a consumer of medical insurance, I am still cheap or dead. This bill is in violation of the Americans with Disabilities Act. It will lead to the unnecessary death of people with disabilities over treatment costs. Many conditions will or may become terminal if certain medications or routine treatments are withheld or stopped. Any person who becomes terminal because they don't receive treatment for any reason would qualify for death under this bill. There is nothing that I see in this bill that would prevent a health or medical insurance carrier from denying coverage of life-belonging or disease-stabilizing medications or procedures, and instead suggesting life-ending medications to an already vulnerable population, either directly or through coercion, or as a secondary or tertiary effect of the ongoing battle for coverage of care. They do their best to wear us down so we stop fighting. I have had many medical providers over the years have zero faith in my ability to heal. I have been abused. I have been coerced. And yet here I am today, and my life has so much value. I am better off alive, and so are all Nevadans who have disabilities. What is alarming to me is that the author of this bill earlier today described a gross misunderstanding of what appropriate hospice care is and what normal death looks like. I encourage the committee to look into that deeper. Further, I see no protections in SB 239 against including any mental health disorder, including PTSD, as falling under the category of terminal. How can we prevent a doctor from saying that all options have been exhausted for someone with PTSD when we don't even have enough competent mental health providers in the state to cover people who are struggling as it is? I absolutely am in firm disagreement with SB 239, and I hope that you will also not support this bill that puts insurance carrier profits over people, especially people with disabilities. And I am happy to answer any questions. Thank you so much for listening.
Thank you for the testimony. We're going to go ahead and come back to Carson City for a few more folks, the folks who are at the table, and then we will go into neutral testimony and have an opportunity at the end to come back around for folks who were not able to make it into this first bout. So please remember to state your name for the record. We'll start with Dr. Cole since you were up here first. Please go ahead.
Thank you. My name is Barry Cole, B-A-R-R-Y, Cole, C-O-L-E. I've been trained as a psychiatrist, neurologist, and anesthesia pain specialist. I self-taught myself hospice medical directing. I became the administrator of 2 national pain organizations, and I was an educator for the AMA's project to educate physicians on end-of-life care, which was the response to Jack Kevorkian. So remember Jack Kevorkian, killed 200 people. Turned out none of them were actually imminently terminally ill. They just kind of came to him and he was willing to oblige. He was a pathologist. He helped them die. I want to kind of address some critical issues. The need for this bill is because we have a failure of our healthcare system. We have providers who are providing care to people that don't know how to provide care to terminally ill people. We're not supposed to know how to do that. We're supposed to cure people. So the idea that we provide comfort care, palliative care, and we forego curative care is sort of an alien concept for how I was trained in medical school. The fact that anyone's dying in America today in agony is proof that something isn't working, because I can assure you, as a pain specialist, 19 out of 20 can be made very comfortable, and data suggests a 15 to 20% reduction in your overall pain intensity correlates with improvement in your perceived quality of life. I don't have to get rid of all of your pain. I got to take the edge off. I've got to make you comfortable. And even in hospice, where I did blocks and I did meds, sometimes I had trouble controlling pain. But what I committed to was changing medicine daily, being in the patient's home daily so that they knew they were never abandoned. There are conditions like locked-in syndrome, end-stage ALS, high cervical fractures, where you don't have use of your hands. I don't understand how you self-administer anything at that point. So quickly, this bill will need to be amended in some way if we're not going to be discriminatory, so that those people can receive intravenous or subcutaneous medications. I don't know when we'll get there, but we'll get there eventually. For me, the heartburn comes from Section 27, which creates a loophole where a psychiatrist is supposed to do what? I could write a report, according to this, that makes a decision about whether or not the patient can make a decision. But the real question is why the attending physician and the consulting physician, when they realized the patient couldn't make a capable decision, didn't just stop. Why do you need to drag in a psychiatrist? Just stop the process. The AMA's curriculum is intended to give alternatives to death in a sterile hospital. It's intended to create opportunities for comprehensive end-of-life care. We can really make people very comfortable, and while I've not had 3,000 hospice deaths, I've had 300, and I was a founder of the Academy of Hospice Physicians, which is now called the American Academy of Hospice and Palliative Care. Pain is, in my opinion, very easily managed for the majority of people, and that we can keep people comfortable until end of life. I want to go back to the beginning of all of this. The original bill in Oregon was called Measure 16. I thought it was ironic it was M16, that those who ended their lives turned out to be white males living alone, often in rural locations, with no social support, who feared being incapable of caring for themselves. My question always was, where was hospice? Where were visiting home nurses? How come these people were isolated and nobody was doing anything about it? Again, a failure of our system. Ending one's life due to lack of care is more about an indictment of our system than it's about making good choices. I believe with proper support, hospice, that takes care of patients in life and their family for 1 year after their death. We provide resources, we provide meds, we provide materials. They don't need to self-destruct, and in my experience, I never had one who did. So I would ask that we take a good deep breath about SB 239. Thanks.
Thank you, Dr. Cole. Next one, please.
Hi, Madam Chair and committee members, my name is Kathleen Rossi, Kathleen I'm a native Nevadan registered nurse who has worked in critical care, and I've taken care of hundreds of dying patients over my 36-year career. I am currently caring for my sister who is dying of a brain tumor. 14 years ago, Peggy was given 18 months to live. Yet another millionth example of doctors getting prognosis of time left wrong. Indeed, if she had utilized assisted suicide 14 years ago, her death certificate would have read cause of death, brain tumor, which shows the deception that is built into these assisted suicide laws and their claims of accurate data collection. Her survival directly affects future prognostics for others with the same diagnosis. She was able to raise a small boy in that time. And I take issue with the proponents saying that these people do not use these drugs until they're in the last stages. There's been several cases where people have taken these drugs when they had months or years to live. These laws are based on the desire for patient autonomy, which granted is a high medical priority, but it is never the only one. Laws should be based on the common good and the effects of the whole of society. Historically, we know that there was a strong push for assisted suicide and euthanasia in the United States in the 1920s and 30s. It was only after the Nazi Germany euthanasia programs were discovered that some of that momentum wore off. But here we are again, as the Hemlock Society has changed its name to Compassion and Choices, counting on the fact that most Americans have short memories and will not see the connection between a physician writing a prescription for death now and the slippery slope to euthanasia. Euthanasia being where the doctor gives you the medication, you don't self-administer. Contrary to what proponents tell you, there are many reported abuses of these laws, and yes, they do escalate. As recently as March, the Colorado Sun reported a 36-year-old anorexic receiving assisted suicide in direct violation of that law that stipulates it should not be used for mental illness. Compassion and Choices even states this on their website. Canada passed physician-assisted suicide in 2016, similar to the law you're considering today. It expanded it in 2021 for the non-terminal, and again last month for the mentally ill, causing many Canadians to have second thoughts about what they have agreed to. Because logically, any argument you make for suffering at end of life, you can make for non-terminal diseases and for mental illness, which is a suffering maybe of a worse kind. The Netherlands just last week expanded it for children. So what I find very disingenuous from Compassion and Choices is that these safeguards that they claim are in the bill, well, we see in other states, they come back later introducing bills to remove the very safeguards, claiming they are now barriers to access. Assemblyman Gonzalez, you asked about the data collection, and I can't refute the proponents in 2 minutes about abuses, but I will tell you who can. That's disability rights groups that document these abuses. I will submit to the committee all of their studies that have shown this. Basically, the physician in Vegas mentioned that there isn't an independent agency overseeing this. It's basically the doctors who are giving assisted suicide who collect their own data. I'm quoting the Oregon Department of Human Services, Dr. Kadrina Hedberg, who says, "We are not given the resources to investigate assisted suicide cases. And not only do we not have the resources to do it, we don't have any legal authority to insert ourselves." Other problems with this bill, it perpetuates falsehoods. It asks doctors to lie about the cause of death. And in a really weird Orwellian manner, it specifies that the term physician-assisted suicide or assisted suicide or mercy killing can never be used, as if by calling this another name, it doesn't make it the same thing. There's no conscious rights at all in here. The doctors must refer or transition. I'm not even sure what that term means. There's a lack of an examination requirement, It requires that a patient be diagnosed with a terminal condition, but there's no requirement that the attending and consulting practitioners actually examine the patient in person or otherwise. What we see in other states is that basically there are a few docs here and there that people search out who are known to be the assisted suicide docs, not the treating physician who has a relationship with the patient. There's no requirement to evaluate for depression, and there's no requirement that the physician be there. All we see is this mental capacity term, which I think could be interpreted in several different ways. We never know exactly
We
what
are at 50 minutes total for
Okay.
opposition, and
All right,
there
I
are still
appreciate
several
it.
people who'd
I
like to
appreciate it.
participate.
Thank you very much.
Thank
Sarah.
you. I'm go ahead and take you here in Carson City, and then we'll do another round of support and opposition. Please go ahead.
Thank you, Madam Chair and members of the committee. My name is Mary Fetchner. On August 5th of 2018, while vacationing in Arizona, my husband of 46 years suffered a paralyzing stroke. During the 6 weeks he was hospitalized, he suffered seizures, atrial fibrillation, and multiple blood clots. He was in and out of ICU 3 times. One tearful night, we said our goodbyes, we expressed our love for each other, and we discussed how to deal with his body after his death. Slowly, his strength and movement began to return. He was moved to rehab and finally released from the hospital. We returned to Reno, where he followed up with intense physical and occupational therapy. Steve worked very hard in therapy and at home. By the summer of 2021, we were hiking in the Sierras. We enjoyed picnics beside beautiful mountain lakes and trails. Then suddenly, unexpectedly, Steve died in the early morning of February 12th, 2022. I am so grateful for the 3.5 years we shared after his stroke. We were never taking each other for granted. Small annoyances were measured against the joy of being together. We lived intentionally and even were able to go on a cruise. I once asked Steve if, had it been available at the hospital, would he have requested physician-assisted suicide or medical aid in dying, or however you choose to use. He replied that after all he'd been through, he would have considered it. Had physician-assisted suicide, or any other term, been legal, we could have been denied the 3 most wonderful years of our marriage, the most loving, caring, giving years anyone could ever hope for. We would have missed out on so many experiences. Please do not deny the possibility for even one couple, one person, one friend or family member. Physician-assisted suicide takes away hope. It removes the potential for a future, and it closes the door for a miracle. I am so thankful that physician-assisted suicide and medical aid in dying or death with dignity was illegal in 2018. Legalized, it would have changed the trajectory of our lives. Thank you.
Thank you for sharing your story. We are going to move into neutral testimony, but as a reminder for folks who are waiting to testify, we will come back to support and opposition testimony. So this isn't an opportunity for soft neutral on either side. This is really for neutral testimony that has no position on the bill. We'll start here in Carson City, move to Las Vegas, and then go to the phones. Please remember to state your name for the record. You may proceed when you're ready.
Good afternoon, Chair. My name is John Abel, Johnabel, representing the LVPPA. Here to testify neutral as the experiences that I've had with, as everyone knows, I would think that police officers respond to every suicide in Las Vegas or in Washoe. Whether they're, and I've responded to several, and several have been terminally ill patients. So whether you approve this bill or not, or you vote against it, keep us in mind, because some of those scenes, and I was wondering if I should get too gruesome or not, and I'm not going to do that. I'm not going to, get into the gruesome details of the suicides that I've seen. But that being said, keep that in mind. Keep us in mind when you're voting for this bill as to what we have to see, because a lot of these people who are terminally ill and no other means to, to other care, they commit suicide, and we end up responding. That's all I have. Thank you.
Would you stand for questions? Mr. Assemblyman Hibbets, I don't know if you had any questions you'd like. Okay, all right. All right, we'll move on. Thank you. Please go ahead.
Good afternoon, Madam Chair, members of the committee and staff. Rick McCann, Nevada Association of Public Safety Officers, and a member of the Nevada Law Enforcement Coalition. I am not here to provide you with any moral guidance or any philosophical compass. I am not good at either one of them. I'm here simply to support my colleague here, Officer Abel, and I do know what he said. Thank you.
Thank you. In Las Vegas, are the people at the table in neutral? If you are, please state your name for the record. You may begin when you're ready. If you're not in neutral, would you mind sitting back in the audience or stepping out for a moment so that folks who may be in neutral can come up? All right, it appears that there's nobody in neutral in Las Vegas. Sorry, I do not have eyes down there, you all, so I see through a little lens. You may sit back down, and we will move to the phones. BPS, is there anyone on Zoom or on the phone line to testify in neutral on SB 239?
To testify in neutral for Senate Bill 239, please press star 9 or raise your hand in Zoom to take your place in the queue.
Hello, good evening. My name is Lorena Cardenas, Senate District 8. Much like abortion, assisted suicide leads to premature death.
This is for neutral testimony only. I apologize. It sounds like this is opposition testimony, and we will come back to opposition testimony, but we are at this moment in neutral testimony only. And we can put you back in the queue.
Okay.
And BPS, please check the line for neutral testimony only, please.
Chair, there are no callers to testify in neutral at this time.
Okay, then we're going to go back into support. We're going to take 10 minutes. So at the moment, we have had 38 minutes of support, 55 minutes of opposition. And I gave a little bit more leeway because there was, we were having a hard time hearing Ms. Hammond. So I added a few minutes into opposition as well. We will add, I'm going to take another 10 minutes in both support and opposition. Really encourage folks to please keep your comments brief. We will take your written comments, but to get as many folks through here as we can, and you guys spent your day here with us, I'd like for you to have the opportunity to speak, but if we have a way to keep things a little more succinct so everyone can get through, that would be great. I'm going to start here in Carson City and support testimony. We'll move to Las Vegas for support testimony, and we'll go to the phones for support testimony. Again, I'm only taking about 10 minutes, so as brief as we can be would be helpful. Please go ahead.
Chair Peters and members of the committee, thank you for hearing this important bill today, and thank you to the sponsor for bringing this bill forward. My name is Annette Magnus, and I'm the Executive Director of Battleborn Progress. And we are here today in strong support of SB 239 because we believe that the real Nevada way is affording our neighbors across the state the freedom to make their own medical decisions, including when they choose to pass. I want to be very clear. As someone who has struggled with severe anxiety and depression my entire life and been very open about that struggle, I also had anorexia in my teenage years, that this conversation we're having today is a very different conversation than what I struggle with in my day-to-day life. I don't have suicidal thoughts, and then we'll be able to use this bill. If you want to have a real conversation about mental health issues in this state, that is a different conversation and a different bill. As someone who has lived with depression and is currently on medication for it, please do not conflate dying in a compassionate way versus folks who are terminally ill and those who have suicidal ideations. It's actually incredibly offensive to us who struggle with this. I would not qualify under this bill unless I was terminally ill, as has been made very clear today by the sponsor. Now for a very different example. When a loved one of yours is in a hospital bed, dying and enduring horrible pain and a lack of agency or ability, the choice to end their pain is one they should not be denied. I have seen this firsthand. I watched my grandmother, who to this day is my idol, die of terminal lung cancer. When they found out, she was given 3 months to live. That was August, and she died on October 26, 2006. She was in the hospital for weeks, coughing up blood, as I watched her waste away before my 12-year-old eyes. She was on so many medications and was hallucinating that there were spiders on the walls and on her face. She was in so much pain, she would cry and scream constantly at the end. She was not the grandmother I knew. She was already gone before she had even passed. I know for a fact if she were given the choice to take this option over the suffering she and my family endured, she would have done it. I will never forget the day we lost her and how relieved I felt that she was no longer suffering anymore. I was raised as a Catholic, and I hope and pray that when my time comes, if and only I am terminally ill, we can all make this educated choice, because I believe it is the most compassionate choice we can give to all Nevadans who desperately need it. Thank you for your work on this critical legislation, and I urge the committee to support SB 239.
Thank you. Is there anyone else in Carson City who'd like to provide support testimony? Just for the record, we missed about, 10 to 15 people who had been here and were waiting for their opportunity who had to leave apparently, which is unfortunate, and I hope that they take the opportunity to write us or send us emails so that we can include their testimony in the record. We will go to Las Vegas. I see a couple folks at the table in Las Vegas asking for support testimony at this time. If you are in support, I would you please take a step away from the table so that
we
support...
are in opposition here.
Right.
There's nobody more in support.
Okay, I don't feel like they would be comfortable coming up to the table with folks in opposition at the table. Would you please take a step back from the table to see if there are folks who would like to provide support testimony at this time? If there's anybody in Las Vegas who would like to come up for support testimony... Okay, we'll move to the phones. BPS, is there anyone on the phones who would like to provide support testimony at this time?
To testify in support of Senate Bill 239, please press star 9 or raise your hand in Zoom to take your place in the queue.
Hello, my name is Les Parks. I'm a registered nurse and I oppose SB 239. I did owe everybody.
I'm sorry. We are on support testimony at this time.
Oh,
I know
I
we're going.
apologize.
That's okay. We are going back around for support and then opposition testimony afterwards. We'll put you back in the queue. BPS, could you check the line for support testimony at this time?
Chair, there are no callers to testify in support at this time.
All right, the hour is late. Okay, so that was about 4 minutes extra of support testimony. I'm going to go ahead and take about 10 minutes of opposition testimony, first here in Carson City. We'll move to Las Vegas and then go to the phones. At this time, I do not believe that everyone will have the opportunity to speak within that 10-minute period of time. I would encourage you to please be gracious to each other in the time that you take. I know we all have stories that we'd like to share, and we would love to hear your stories. We are more than happy to review your stories in written format. You're welcome to send them into the committee, and they will be distributed to the entire committee. Please state your name for the record. You may begin when you're ready.
Thank you, Madam Chair and members. My name is Maria Jose Fernandez Flores. I am the Coalition's Director for Patients' Rights Action Fund, a leading national nonpartisan single-issue organization that protects the rights of patients, people with disabilities, elders, and people who are poor from deadly harm and discrimination inherent in assisted suicide laws. We advocate for all patients to be treated with equal human dignity, no matter their health or disability status, nor a perceived low quality of life. As a Latina, DACA recipient, and someone who grew up low income, I see the dangers that this legislation will bring to my community. I went many years without health care due to my immigration status, and when I finally had the opportunity to qualify, the high cost made it extremely difficult to seek help when needed. I would not seek adequate preventative treatment because it would be a financial burden on myself and my family. Therefore, I only visited when I was in extreme pain or sickness. So now imagine the distress that I would be in if I were to have gotten diagnosed with a terminal disease at that time, and assisted suicide would have been legal in the state that I was growing up. When given the choice to choose to persevere and seek treatment or to take my life away, I would have probably chosen the latter due to the financial burden the former would have been on myself and my family. I do not want that situation to happen for anyone. People should not feel forced to make a decision they do not want solely because of lack of access, funds, or support. We cannot talk about true autonomy and choice without having equal access to health care. SB 239 endangers disadvantaged, diverse populations often overwhelmed by institutional bias for disproportionate tracking toward or imposition of grave outcomes, and has widespread inadequate healthcare options. And it has widespread implications in a historically racially oppressive society. Those who suffer most from inadequate healthcare options are the financially poor, the illiterate, the poorly educated, the addicted or mentally ill, the non-English speaker or English language learner, the disabled, and culturally diverse. The proposal of SB 239 is offensive to myself and my community, where the attention should be focused on just and quality healthcare, including palliative care and caregiver support for all minorities, not just the wealthy and privileged. I ask for a no vote on SB 239, and before I end, I would like to add that the lawsuit that was mentioned earlier is a real thing. It was just submitted yesterday, and that is probably why not everyone is aware. It is challenging the violation of the ADA Section 504 and constitutional due process and equal protection provisions. You can go to the website endassistedsuicide.org for more information. Thank you.
Thank you for your testimony and your story. We are about to lose our Las Vegas location, and I know these two women have been waiting, so I would like to move us to Las Vegas to take these two folks in testimony. Please remember to state your name for the record. You may begin when you're ready.
Christiane Mersch, last name M-E-R-S-C-H. I'm representing Nevada Right to Life, and I'm here to oppose SB 239. We should take as an example what is going on in Oregon right now. Assisted suicide laws has failed to safeguard disabled and elderly people. It's difficult to control coercion and abuse. So most of people that has disability is the ones that are against this bill. So it's perpetuates discriminatory attitudes toward the disability community and the vulnerable. Assisted suicide laws opens the door to promote a society who judges who lives and who dies. Never in our reading Founding Fathers you could hear the word right to die, but the right to life instead. So Assisted suicide, it's never going to be a solution or a substitute for medical care, because assisted suicide, it's not a medical care. And as you heard here today, many doctors, in opposing this bill, their oath is to heal and to do everything they can to help and comfort that patient that is suffering pain, but not to help them to die. So I please ask, oppose this bill. Thank you.
Thank you for your testimony. Thank you. Please state your name for the record. Go ahead.
Hello, my name is Rosanna Santos, Santos. I am a social worker. In my profession as a social worker, I witnessed working with the elderly facility rehab center, and I saw a lot of patients, relatives, taking advantage of their vulnerability and try to exploit them. This bill will not protect the adult vulnerable. We should not assume they want to die because they are in pain and they are unable to decide. Please vote no to SB 239. Thank you.
Thank you. It looks like one more person has come to the table in Las Vegas. Yep, please go ahead. State your name for the record.
CYRUSHOJJATY. Ditto. Yield.
Thank you for the effective testimony. Appreciate it. We will come back to Carson City as we're losing our Las Vegas location. Thank you all for those who are in attendance for SB 239. We'll come back to Carson City and take the three of you at the table, and at that time we'll probably be at the 10 minutes. Please go ahead.
Madam Chair and committee members, my name is Lisa Bedard-O'Laughlin, and I'm testifying against SB 239. Cancer took the life of my father and 58-year-old brother. Both received hospice care, thankfully. Experiencing the process of dying with them taught me that dying is not to be feared, and allowing it to unfold naturally provides time to express your love, provide care for them, share a last martini, or in the case of my brother, who was very much afraid, reassure him that he would not be alone and he would not be in pain. And that turned out to be true. I was with him. He breathed his last breath with all of us around him. My own recent cancer diagnosis also informs my opposition. Should my cancer return, this bill incentivizes my insurance company to deny me life-saving treatment. Additionally, as I approach Medicare age and watch the explosion of federal debt, I suspect the government will continue to seek ways to reduce the funding of care. This bill will put the lives of elderly Nevadans at additional risk. If implemented, SB 239 will harm lives by giving insurance and government bureaucrats control over them. Additionally, as I watch more and more physicians and hospitals, or physicians work for hospitals and insurance companies bundle payments to hospitals, it will create a perverse incentive to deny care and for doctors to just give a pill because it's cheaper. Their pay is going to be based on how much they spend. This is not a bill of compassion, as it devalues human life and ultimately takes control away from patients. Its unintended consequences outnumber its benefits, and as we've heard, guardrails don't work. They come back and chip away at those. Find the courage to vote no. It turns healers into agents of death and breaks the bond between patients and their doctors, and will hasten the death of people who want to live. I know that I want to live because I had to think about that a lot last summer, and I know that I don't want a stranger deciding whether or not I get to live. Thank you.
Casey Rogers for the record. I have to say the opposition is on fire right now. My concern with this bill is that it makes human life less significant than it ever has been by the hands of the people who make laws and legislative policy. When you start with assisted suicide, where does it go from here? Is it about money or is it about compassion? Is it about a depopulation agenda? Does this give parents the option to kill their child because it was born with a birth defect? If not, when? Can children and teens that are suicidal get a hold of this medication and use it because they were bullied at school? The aforementioned is just some of the concerns, but what about the idea of allowing someone and helping murder someone else? Hereafter,
How are we to view murder and suicide? Jews and Gentiles alike, we were given the 10 Commandments. The 10 Commandments says, thou shalt not murder. Whether you believe that or not, we have a moral compass and ethics that we are supposed to abide by when it comes to human life. The last thing I want to say, it is a gross negligence to say that mental health is not something that you should look at when looking at this bill. It is definitely something you should look at. And I have friends that all have been on the battlefield. They have lost limbs, arms, and have been burned almost to their death, many of them suicidal. But when they're able to see their family and they come in and they see their family, they decide, I want to live. So where does it go from here? Does the battlefield become the next place we say, screw it, you can just die? I'd like to know.
Madam Chair, members of the committee, Melissa Clement, MELISSA-CLEMENT with Nevada Right to Life, here in opposition. There is a tremendous amount of issues that the proponents of this bill brought up, saying there has never been instances of abuse and misuse, and there are. I would ask you all to read. I'm going to submit a document that talks about the instances of abuse and misuse that have been documented. We have several years of Oregon, Washington, Canada, and other countries. So we have a body of knowledge. And yes, unfortunately, Dr. Brian Collister is not here because he could testify. He's in Nevada, very talented doctor. He asked for life-saving treatment for a patient here in Nevada that was from California and one from Oregon. They were denied. The insurance companies in both situations asked him to talk about assisted suicide. He has submitted something. Also, the safeguards against depression are truly inadequate. If you look at the bill, it talks about defining the person as mentally capable. Mentally capable. Please look at the definition. It has nothing to do with a mental health screening whatsoever. There is no screening for depression. And there isn't even a requirement for a screening for depression. And anyone who's had a terminal diagnosis knows that depression is one of the first things that happens. Having walked this with three family members, I know that for sure. There are many problems with this bill, and I know that there are some people on the telephone that would like to talk, so I'm going to cut myself short, and I appreciate your fairness, Madam Chair.
Thank you. And it is a balance, and I know it's hard to strike. So I appreciate you all sticking around and bearing with us as we moved through a long day. We have exceeded that 10 minutes by a little bit, and I don't have it in front of me, but we started at 5:35 and it's now 5:48. So we didn't make it through everybody, and I apologize for that. But please remember that those written testimony will be a part of our record if you want to send them in up to 24 hours after we adjourn today, and we will all get copies of those as committee members. So I would like to invite the committee sponsors at all to come up for closing comments.
Johanna Koch, for the record. And I want to thank all of you for your patience this day. It's been a really long afternoon, and I'd love to stay after and talk to anybody who still has the energy to stay after and talk. I would also like to say that with regards to capacity and depression, this is a really complicated issue. But the bill, the diagnosis of depression doesn't qualify you for medical aid in dying. It also doesn't disqualify you for medical aid in dying. In other words, you can admit to being depressed, but if you still have a terminal illness and you're not acting out of an impulsive response to your depression, and your depression has been managed to the best of the medical world's ability, then you can still, if you have the right terminal diagnosis, qualify for medical aid in dying. So I wanted to start by clarifying that point. And then also with regards to consent, the question that I wanted to respond to was, who can provide consent? There's concern that people with disabilities might be picked on, people who are poor English speakers or who are learning English, people who are elderly or in some other way at risk. And that population is very unlikely to fall into the category for medical aid in dying. But if they did, they would need to be able to demonstrate clearly and succinctly what their reason for requesting it was, in other words, what their medical condition was, what the consequences of their action would be, what alternatives they have to treat that condition, and that they understand what would happen if they requested medication. And so, a person who is challenged in any way that would make them special needs or disabled is not going to qualify easily for medical aid in dying.
Thank you, Doctor. I simply want to say that we don't need to speculate about how this law will work. We have decades of data and experience, and I believe, and I filed the report and I'll check it, but I believe over 90% of patients who use medical aid in dying are enrolled in hospice. They have an interdisciplinary team of professionals who are focused on the comfort and the psychological well-being and the support and providing every possible treatment, not just for the patient, but for their families. Hospice also provides spiritual care, whether it's in residential or at home. This is an additional layer of protection, ensuring that patients who request medical aid in dying and follow this process have employed every means possible to relieve their suffering. There are many hypotheticals about this, but this is what we know. And that's why Nevadans are asking for the same option for themselves, if they should choose, as people in 10 other states. Thank you for your time today.
Thank you. Thank you again to all who have stuck around for this long meeting. I'll go ahead and close the hearing on Senate Bill 239, which brings us to the end of our hearing agenda today. We will move into our last agenda item, which is public comment. We will start in our Carson City location and then move to the phones. If there's anybody who would like to provide public comment, we are limiting public comment to 2 minutes to ensure fairness and opportunity to speak. And we will start here in Carson City. Is there anybody who'd like to provide public comment in Carson City? Seeing none, BPS, is there anyone on the public line who would like to provide public comment today?
If you would like to provide public comment, please press star 9 now to take your place in the queue.
Hello, my name is Celeste Parks, and CELESPARKS, and I'm a registered nurse in Nevada. And I recently just came across that Nevada ranks 50th nationwide in healthcare. That's really terrible. So we have a lot to work on. Throughout all of these bills that have been being put past in the last few months, I would ask one of you to put forth a bill that goes towards the benefits of raising Nevada from the worst to the best. Healthcare is never going to, the Nevada healthcare will never be to what it needs to be unless there are laws that are passed to help improve our healthcare in Nevada. It's really sad to know that as a registered nurse, and it's embarrassing to know that we work in the worst state in the entire nation compared to other healthcare states and healthcare in other states. We are approximately 10 years behind in Nevada. So I would just ask you legislatures to put forth a bill that would actually help the healthcare, help communities, help the people of Nevada just improve on just healthcare as a whole, and that would help and not kill. Again, My name is Celeste Parks, and I definitely vote that we put a bill towards improving our healthcare.
Thank you for your public comment. BPS, are there other callers on the line for public comment today?
Chair, there are no other callers choosing to provide public comment at this time.
Thank you. And again, I just want to state that my sincere apologies to those who did not make it into calling in particular for testimony today. Please send in your written statements. We will keep an eye out for those and review those when they come in. I will close out public comment at this time, and we will have a meeting on Friday, y'all. I will not be here, but Vice Chair Orrin Licker will be chairing that meeting for the day. With that, we are adjourned.